5:30. So yeah. So after the grace time of 5 minutes, I think we'll start with our discussion. So I think whoever is joining, they can join whenever they're free. So I'm assuming that you've all attempted your mock test and then you have been attending this debrief session. So first of all, how was the questions? I mean, were they expected? Were they hard? How was it? So anybody can give a feedback. Hello. Okay, so without wasting much time, so we'll go into the debrief session. So first we'll discussion. So somebody says it was a little bit hard. Okay, so I intentionally kept it hard so that you should not take this module very lightly, very highly scoring. Okay, so there are some fixed set of questions. So very highly scoring, so you can easily get good scores in this particular module. Okay. So we'll have two CCS sessions and then CVS questions, and we'll try to keep it interactive. And whenever you have any doubts, you can stop me there and ask the doubts. Okay. So can you all see the slides?
Sir, we are unable to see the slides.
Okay.
Yeah, it's coming.
Now?
Yes.
Okay. So without wasting much time, I think we'll go into the debrief session. So first one was the obstetric CCS. Okay, and I've tried to cover almost all the questions you can expect from the obstetric part. As I said, it's a very easy scoring topic. So, and you should know all the complications, all the critical care issues which you see in your pregnant patients. So let us go with the case scenario and start the discussion. So this was a case of a 36-year-old female, G3P2A1, a woman of 32 weeks of gestation, was brought to the ICU with severe pain in the upper abdomen since this morning. So this was associated with breathing difficulty since last 2 hours. So pain abdomen, breathing difficulty. Her BP was 168 by 120 millimeters of mercury. Heart rate was 110 per minute. Respiratory rate of 32 breaths. And it was shallow. SpO2 was 90% on room air and improved to 97% on the face mask with 4 liters of oxygen. The fetal heart rate is 144 per minute. There was some associated blurring of vision and headache on and off. There was sudden increase in pedal edema since last 2 days. So there's no history of any issues during her present antenatal visits, but there is some history of premature termination of previous pregnancy, which was approximately around the gestational time of around 22 weeks. So some history of seizures is there during that termination. So there's no history of any other medication intake or drug allergies. So what is the probable diagnosis? Anybody? So what do you think you're discussing? Yes? Correct.
Preeclampsia.
Yeah, so we need a little more, but anyways, your differential diagnosis at this point will be preeclampsia, correct? So
Okay.
other than that, so you should have the other differential also. So you can still be gestational hypertension. So preeclampsia, in this particular case, it is preeclampsia. You can see this patient has some breathing difficulty and all. So it could be because of preeclampsia induced pulmonary edema. You know the severe form of preeclampsia, and there is other organ dysfunctions also. So this could be a case of preeclampsia with pulmonary edema, and some CNS symptoms are also there. So some CNS involvement as well. There can be a possibility of gestational hypertension also. I will tell you the definition in the subsequent slides. That is also still possibility. Okay, so gestational hypertension can be there, though they say the previous antenatal visits were nothing significant, but still anybody before 20 weeks of gestation, if they had hypertension, that can continue during the pregnancy also. That condition can be called gestational hypertension if there is no proteinuria. If there is proteinuria, it becomes preeclampsia. Okay, so there is a condition called overlap. Gestational hypertension and preeclampsia both can be seen together. That is, you have a patient who has gestational hypertension from the even before your pregnancy. It continues during the pregnancy, and there is new onset proteinuria during pregnancy. So there is both gestational hypertension as well as preeclampsia. Other rare differentials include your acute coronary syndrome and sometimes peripartum cardiomyopathy. You also know peripartum cardiomyopathy is seen after 20 weeks of gestation, and there is involvement of sudden decrease in the cardiac function. So this is also possibility, but a less likely cause because your patient has some pulmonary edema, SOB. So this is also in the differential. So how do you manage this patient? So in your CCS, you'll have questions on management of the patient, whereas in your CBS, if you get the same thing, you will be asked about management, but you need not tell all those details like ABC. You can tell it in one line and can go to how do you manage your patient. So in this case, so because this patient has various symptoms, so resuscitation is the first thing. You look into airway, breathing, and circulation. We have seen from the history that airway she is maintaining for now. Breathing, she was requiring some oxygen, and we are continuing oxygen. But if at all there is any distress, any worsening of the patient's pulmonary edema or breathing difficulty, we're going to start a patient on NIV. But as of now, she's okay with oxygen, so we'll be continuing that. Next, we saw that her blood pressures are very, very high, and we are suspecting a case of preeclampsia. So we need to bring down the blood pressure. So antihypertensives are required to bring down her blood pressure, though there is no hypertension, and we need to give diuretics for pulmonary edema. So we need to evaluate. So correct, we are suspecting preeclampsia, so we need to evaluate our case. So we need to have some blood investigations. So what will I like to do? So you can do, so your management includes first stabilization of the patient, clinical management of the patient, and then comes to evaluation of the patient by doing some blood tests or some other investigations like complete blood count, renal function test to know whether renal parameters are involved, liver function test, because we know in severe preeclampsia there is involvement of other organ dysfunction is also there. Even in preeclampsia it is there. So you need to know the urine protein creatinine ratio. So USG abdomen and pelvis. Also fetal ultrasound to know the viability and any consequences of the fetus, and even a 2D echo because she comes to us with SOB, and we are still one of our differentials is peripartum cardiomyopathy. I would like to do a 2D echo as well. So how do you come to the diagnosis of preeclampsia? I think all of you know this. So any new onset hypertension which is seen after 20 weeks of gestation, and there should be associated proteinuria and some evidence of end organ dysfunction or uteroplacental dysfunction. So there should be two or three, two of the factors. So one, definitely it should be a new onset hypertension which is there after 20 weeks of gestation with proteinuria. These two are mandatory. Hypertension and proteinuria mandatory. And apart from that, there should also be a evidence of end organ involvement. Like in this case, we have cerebral involvement and some pulmonary edema is there. So those should be there. Or some cardiac dysfunction is there, which is called pulmonary edema. There is pedal edema as well. So these should be there, or there should be uteroplacental dysfunction. So three factors should be there of the four. Okay. So and what is a hypertension? So hypertension is defined as BP more than or equal to 145 in 90 millimeters mercury. We should be there on two occasions, not just on a single occasion, but on two occasions, which is measured at least 4 hours apart. And you see that this BP is more than 140 by 90, then this is a case of possibility of preeclampsia. Apart from that, you should have proteinuria. How do we say there is proteinuria? When the protein creatinine ratio is more than or equal to 30 milligrams per millimole. You can't do a 24-hour urine protein. Instead of that, the simplest thing you can do is a protein creatinine ratio. If it is more than or equal to 30 milligram per millimoles, then it is said to be significant. So there is high blood pressure, proteinuria, organ dysfunction, or uteroplacental dysfunction. Now coming to diagnose preeclampsia with severe features. So again, there is a subclassification of your preeclampsia in those patients who have severe features, like in our patient right now. So what are those severe features are? Systolic blood pressure more than or equal to 160. I think our patient fits into it. Or any of the following features like cerebral involvement, complaints of headache, visual disturbance, altered mental status, and otherwise unexplained severe right upper quadrant pain, elevated serum transaminase more than 2 times the upper limit of normal, decrease in the platelet count to less than 1 lakh, progressive renal insufficiency, or even pulmonary edema. So any of these, if they are present, it is severe preeclampsia. So all of you agree, our case has a blood pressure more than 160. So there is severe preeclampsia. She has some CNS involvement. There is pulmonary edema, and we don't know the labs. So even if the labs come, there may be other features which will tell that our patient has some severe preeclampsia.
It
So
can
what are
be,
the differences for high B? Yes, yes.
sir, it can be DDs, can be acute fatty liver of pregnancy.
We still don't know. I mean, though she has some pain abdomen, but there is accelerated hypertension, so we can straight away go with. So if you have some elevated transaminase, liver dysfunction, hypoglycemia, then it will go with the AFLP. But we are purely right now we have only clinical history. We don't know have any labs. So there is high blood pressure. So it is straightforward. I think it is preeclampsia only. So differential,
So
I don't
there
think.
is so there is any
Yes, yes.
chance for the praise or and help as a differential diagnosis
Yeah,
as
yeah.
the
Press
patient
can
is
be there. Yeah, can be there. So press is a possibility. You can put it as a differential, but keeping
and
everything
also
in mind because there's pulmonary edema, there's cerebral involvement is there. So press is possible because cerebral involvement is there, high blood pressure is there, press is a possibility. But AFLP at this point, no, I think. Maybe if you get some labs, hypoglycemia, transaminitis, AFLP is possible. But press can be there in the differential diagnosis.
So I have
But
another
this is
question.
straightforward. I think first differential is preeclampsia. After that, you can add gestational hypertension, press syndrome. So all of those you can add.
So as my patient is preeclampsia with a severe organ involvement,
Correct.
in case of the management, is there any option for prophylactic magnesium sulfate as per
Yeah,
MAC
yeah,
5
it is there.
study?
We'll discuss. We'll discuss. Yes, yes, we'll discuss that. Yeah, yeah. There is requirement. Yeah. Okay. Now coming to the differentials. So anybody wants to tell what are the other differentials for high blood pressure during pregnancy? I already told a few of them. So this is how you will work up. So you have a patient who's been, he's pregnant, she's pregnant, and you see that there is high blood pressure. You'll see what is the gestational period. If it is less than 20 weeks, usually it will be chronic hypertension. Means your patient was already a known hypertensive. Now is less than 20 weeks of gestation, because we see most of the related to pregnancy will have hypertension after 20 weeks of gestation. Whereas this, if you see if it is less than 20 weeks, then it is usually not related to pregnancy. This is mostly a case of chronic hypertension. Okay, so it was there, maybe may not have been diagnosed before pregnancy. Now you're identifying it. If it is more than 20 weeks, and next you check for proteinuria. So if there's more than 20 weeks and proteinuria is also present, then it becomes your preeclampsia. So even your patient, say known hypertensive, can also have proteinuria. And if he has proteinuria during pregnancy after 20 weeks of gestation, then he'll be into superimposed, this classification of preeclampsia superimposed on chronic hypertension. If he develops new proteinuria with high blood pressure after 20 weeks of gestation, it is chronic hypertension plus preeclampsia. Okay, so next, proteinuria, high blood pressure, it becomes preeclampsia. Next, you look into what are the severe features if your patient has. So you look into SPP if it is more than or equal to 160 millimeters mercury, or diastolic blood pressure more than 110 millimeters of mercury. Acute kidney injury, elevated liver enzymes, thrombocytopenia, pulmonary edema, new onset of headache, visual disturbances, seizures. So all these are severe forms. And when you know that if there are seizures with preeclamptic features, then it becomes eclampsia. So you see more than 20 weeks of gestation, but you see there's no proteinuria, then it becomes gestational hypertension. So this is how you identify your case with hypertensive disorders in pregnancy. You say whether it is just chronic hypertension or gestational hypertension or preeclampsia. Okay. And we know that any patient with high blood pressure, elevated liver enzymes, thrombocytopenia with involvement in hemolysis, so we have a subclassification called HELP syndrome. Okay. So we'll discuss all of this. So going to the vignettes, so we saw our patient, we made a differential diagnosis for the condition. Then we have asked for a few blood tests, but during her stay in the hospital, she had an episode of seizure. So the patient remained drowsy and the saturation started to drop. So during her episode of seizure, so she became very drowsy and her saturation started to drop. The patient was not maintaining her airway. So what do you do at this point? Yes, anybody?
Endotracheal
Again, you start with your ABC, correct?
ABC.
So, anyways, it is already told that he's not maintaining airway, so you need to do something about the airway. So, what is the first thing you do? So, because your patient is not decreased responsiveness, not maintaining the airway, first thing you'll do is put her into lateral position so that she doesn't aspirate anything till the consciousness becomes better, or till you secure the airway. You will do this. So, as the patient is not maintaining her airway, she requires endotracheal intubation for airway protection. And as I told you, this patient is already having seizure. We should have started magnesium sulfate earlier, but before we could start, she already had a seizure. So, as somebody asked, so there is a role for prophylactic magnesium sulfate, so that you prevent the consequences or prevent the severe forms of preeclampsia. It reduces the seizure potential as well. It reduces the blood pressure as well. So there is role for prophylactic magnesium sulfate even if you don't have a seizure. Okay, so these are the things you will give for your patient. So next came the question: any flow changes in the airway and respiratory system during pregnancy? So you decided to intubate your patient. So what are the common physiological changes that happen during pregnancy with respect to respiratory system? Yes, anybody wants to tell? It is there in the slides, but still, who has attempted the questions? So what are things you mentioned in your
So
Google form?
yeah, airway, there is a change of the airway, become edematous, neck,
Correct.
breast, inners
Yeah,
is
neck is
increased,
short, obese,
short
breasts are
neck,
big.
obese,
Yeah,
and also
diaphragm is
intrapulmonal
obese.
pressure, and
Correct.
also there is an increased tidal volume, minute ventilation.
Yeah,
There
increase
is a
in minute ventilation,
respiratory.
decrease in FRC, decrease in tidal volume. There is more hyperventilation. Correct. So there is shallow and more rapid breathing. So the increase in minute ventilation, they're usually on the alkalotic side. They wash out little carbon dioxide.
Yes,
So these are all the
increase.
changes which you usually see. Apart from that, because there is, if the patient is near term, there is relaxation of the lower esophageal sphincter. There is increased risk of your patient having regurgitation, vomiting during, if you put the patient in supine position for intubation. And I told you there is significant amount of edema. So if you're planning to intubate your patient, always select a one size smaller endotracheal tube compared to a regular female who is non-pregnant. And you have a Malnapatti, say at the start, before the pregnancy, if a Malnapatti would have changed. So it mainly says this is an anticipated difficult intubation case. Okay, and usually if you're planning an intubation, you'll always call for an expert. Okay, and you will keep the number of attempts as less as possible. So these are all the airway changes that happen during pregnancy. So what are the common challenges? Anyways, we know the consequences. I mean, you know what are all the different things. So these are all the common uh, consequences which you will see during your pregnancy. Sorry, 1 second. Okay, so what are this? I told you aspiration is a very high risk. You all have heard about Mendelssohn syndrome and all. So these patients, already their sphincters are all relaxed. So when you put this patient to supine position before intubating, so they are at high risk of regurgitation, aspiration, and causing pneumonia, pneumonitis. So what is the recommendation? So you need to give, so whatever it is, so at any time after 20 weeks of gestation, if your patient is coming for, you are planning to intubate your patient, so always consider full stomach, even if they say they are NPO for significant amount of time, but still it is considered full stomach. Okay, so you should do a rapid sequence intubation. So this is all or how you will manage. So you'll give sodium citrate is a recommendation to prevent Mendelssohn syndrome. They are at high risk of desaturation because their FRC is very, very less, and they have increased oxygen consumption because the mother is hypermetabolic. There is oxygen utilization with the fetus as well. So there is increased consumption, but the FRC is very, very less. So like how we usually do our intubation, we pre-oxygenate and fill the FRC with 100% oxygen so that we get no desaturation during our apnea time when you are intubating the case. But say this is not the case in case of pregnancy because the FRC is very less and the oxygen which is stored in the FRC also gets consumed very fast. So your patient tend to desaturate very fast. So you don't have that luxury of having a very significant amount of apnea time. So you need to modify. You need to intubate your case as early as possible. Okay, modified RSI you should consider. It's always a difficult intubation situation, I told you. So if the breast is big, the patient is obese, you need to put it in ram position. You can use a smaller endotracheal handle, laryngoscope handle. So all those things, you can use your fiber optic bronchoscope. You keep the difficult airway card ready during intubating these patients, and always try to avoid. So we are always worried when we are intubating a case whether to give particular drugs or not, because we are always worried whether these drugs can get transmitted to the baby and can cause some respiratory depression or sedation in the baby. So don't worry about that, because as long as you are taking care of the mother well, the baby will also be okay. So don't hesitate to give adequate doses of opioids, or your usually we don't give benzodiazepines, but opioid should not be a problem. So only thing is, if it crosses the placenta and causes some respiratory depression in the patient, you can give naloxone and treat for the baby, but don't worry about it. But if you don't give it, and you, especially in this particular case like preeclampsia and all, if you attempt to do laryngoscopy without adequate sedation, so then it can lead to severe raise in blood pressure and can cause intracerebral hemorrhage. All those risks are there. So there is risk of laryngeal edema also. As I told you, select a smaller size tube. And you know, when you put your patient in supine position, there is aortic risk of aortic cavity compression. You can suddenly see that the patient's having drop in blood pressure. The only thing you need to do is just do a lateral manual uterine displacement, so left lateral displacement, so that the IVC, the pressure on the IVC gets relieved. There is good amount of venous return, and the hypotension will automatically get corrected. So these are all the precautions you take, or these are all the challenges you face during intubating your case during pregnancy. Okay. Now coming to what are the principles. So whenever you're managing a case of preeclampsia, what are all the things you should be considering? First thing is, so always try to bring down the blood pressure. You can treat severe hypertension and try to bring it down to less than 160 by 110. No need to bring it down to normal, that is 120, 80. No need to bring it down so much. I'll tell you why. So, but try to bring it down to less than 160 by 110 if it is more than that. Okay. So closely monitor mother and fetus. Always don't forget to monitor the fetus. We need to monitor both of them. Okay. So optimize delivery timing. So if it is already very severe, and we all know the best thing and the definitive treatment for controlling preeclampsia or eclampsia is to deliver the baby as early as possible. If it is near term, I think we can take that risk and deliver the baby. Or nearing term, you need to think about fetal lung maturity, and also can give some steroids for fetal lung maturity and try to deliver the baby once the mother is little stable. And always try to prevent seizures. As I told you in the previously also, you can start magnesium sulfate empirically only, even before the patient has seizures. So you can start them so that you can prevent preeclampsia going into eclampsia. So these are all the key principles you will be considering when you are managing your case of preeclampsia. So that's what I was talking about, how to reduce the BP. So don't try to bring it down to normal. So set your goals. So extreme BP elevations. So if it goes very high, so we all know there's risk of cerebrovascular accident. There can be intracerebral bleed. Also cerebral autoregulation happens. And when the blood pressures are very, very high, even there are high risk of your patient having placental abruption. As I said, don't try to bring it down very drastically, because all your system, your placenta, intraplacental circulation, and rest of the body would have got used to that high blood pressure. You suddenly bring it down, they'll have ischemia there. So it'll lead to compromised blood flow. So don't bring it down rapidly. So because mainly it will affect the intraplacental blood flow, and it can lead to fetal distress, fetal death is also possible. So always try to decrease it to less than 25%, up to 20 to 25% over minutes to hours. Don't bring it down suddenly. So gradually bring it down, and always try to keep it to less than 160 by 110. No need to target it 120, 80, but it is adequate if you bring it down to 160 by 110, and gradually over minutes to hours, bring it down. So what are the options available? Yes, anybody? So these are the drugs which have been found to be safe the most, because when there is hypertensive crisis, they can't try a oral form. So always try with IV labetalol as the first choice drug. So there are other drugs like IV hydralazine, paroral ifidipine, paroral methyl dopa, paroral clonidine. So these are the drugs which are commonly used during pregnancy to reduce the blood pressure. This patient had a seizure. So what are the common etiologies? Definitely you all know it is eclampsia, but you should not forget other differentials as well. So most commonly any patient pregnant, high blood pressure, having seizure, definitely it is eclampsia unless proved otherwise. But you should rule out other causes as well. So other causes can be cerebrovascular accident. We had a patient who had high blood pressure, some CNS symptoms as well. So there can be a chance of this patient having cerebrovascular accidents. Brain tumors can be a possibility. Infection, TTP, hypertensive encephalopathy like a Press syndrome is also a possibility. Epilepsy is also a possibility. Maybe this patient had previous episode of seizure. Now again she's presenting a seizure, so epilepsy is also a possibility. So these are though not. We all know it is straightforward case of eclampsia, but still you should know these differentials. And these differentials are very, very important, especially when your patient has some focal deficits. So she's not moving one limb or not moving one side of the body, or has some weakness on one particular side, some facial drooping is there, something like that is there, then you should definitely be considering one of these differentials. Okay, otherwise it's a straightforward case of eclampsia, but you should tell a few differentials. Okay. So how do you define eclampsia? So we saw the definition of preeclampsia. Now going to the definition of eclampsia. So you have a patient who is having preeclampsia, and that patient develops, and not just preeclampsia, it is severe form of preeclampsia. We saw that high blood pressure and seizure. So again, eclampsia is a convulsive condition, which is the most severe manifestation of preeclampsia. So one of the most severe manifestation of preeclampsia. How do we define it? It's nothing but a new onset of tonic-clonic seizure, endor or coma, even altered level of consciousness in the absence of other causative conditions. So you see there is no other obvious cause causing this seizure or coma, and your patient has preeclampsia, then it is a case of eclampsia. So next, mention other neurological complications that can occur in preeclampsia with or without seizures. What are the other things you can expect in this particular patient? So your patient comes, pregnant patient coming to you with seizures. What are all the other differentials you have? As I told you, cerebral venous sinus thrombosis is also very, very common. You saw in this particular case, she's an elderly female. Some previous history of abortion is there. So cerebral venous sinus thrombosis is also another common condition which can present during pregnancy. We know pregnancy is a prothrombotic state. So there is high risk of her developing venous sinus thrombosis, also very common. The other conditions can come to you with altered sensorium or some neurological complications with seizures include your reversible cerebral vasoconstriction syndrome. Other one is your PRESS, that is posterior reversible encephalopathy syndrome. There can be some SAH when there's high blood pressure. So if the patient had some aneurysm, there is chances of this patient developing a subarachnoid hemorrhage, intracranial hemorrhage, and even ischemic stroke is also possibility. So these are all the conditions which can present during preeclampsia with or without seizures. Okay, these are all the neurological complications. If anybody asks you what are all the differentials for a patient with high blood pressure in preeclampsia coming to you with seizures, so these are all the differentials for those conditions. So how do you manage eclampsia? I told you, emergency care. Whenever the patient is having a seizure, you need to monitor the patient airway, breathing, circulation, take care of the patient so she doesn't injure herself. So ensure health and safety of the mother and fetus. So start them on medications to stop eclampsia and prevent the recurrence. It's not only you are stopping that particular episode, but also you should take care that she doesn't have further episodes, because every episode of seizure is going to harm the mother as well as the fetus. And we all know this is a case of eclampsia, so it is all happening because of high blood pressure. So start them on immediate antihypertensive drugs and try to bring down the BP as early as possible. So that itself will reduce the further episodes of seizures. So we'll see what drug to start. So what is the definitive treatment? So this is what I was talking about. So evaluate and see what is the maturity of the fetus and all. We all know definite treatment for eclampsia is delivery of the fetus as soon as the patient is stabilized. So once you stabilize, this patient has a seizure and he is near term, the fetus is all good. So you don't want to take risk. So you can straight away go ahead with stabilization of the patient and immediately plan for delivery of the fetus. And once the delivery happens, so all the eclampsia or preeclampsia both will come under control. So what is the drug of choice for preventing seizures in preeclampsia or even for preventing subsequent seizures is magnesium sulfate. Correct. So you can empirically, you have a patient who has preeclampsia and you can start them on magnesium sulfate. Don't need to wait for them to develop a seizure and then start magnesium sulfate. If the blood pressures are very high, you can empirically start them on magnesium sulfate. That will prevent a first episode of seizure. Or if it is started after the first episode, it will prevent further episodes of seizure. Okay, so this is the drug of choice. So how do you manage seizures in this patient? I told you magnesium sulfate is the drug of choice. So anybody knows the dose? It is there in the slides.
Yes, IV, 4 to 6 milligram IV, then 1 to
Yeah.
3 milligram per hour. If
Okay.
and in case of IM, 4 milligram
Mhm.
IM and 4 hours interval as alternative bottle, and it is
Correct.
continued for 24 hours.
Correct.
Uh,
Okay, so this is the dose. So I think your dose were little not correct. So drug of choice is magnesium sulfate, as said. So a 4-gram loading dose followed by an infusion. So 4 gram can be given over a period of 4 to 5 minutes. After that, you start an infusion. The recommendation is 1 to 2 grams per hour. Okay, so 1 to 2 grams per hour, and it should be continued at least for 24 hours. And again, few books say 4 to 6 grams of the loading dose. So whatever it is, so 4 grams is the loading dose followed by 1 to 2 grams per hour infusion. So if you don't have IV access, so if you are planning to give IM, then the loading dose is 10 grams. You give 5 grams in each buttock, and the maintenance dose is 5 grams every fourth hourly in alternating buttocks. Okay, so this is your IM dose. If seizure persists, say I gave magnesium sulfate, has been adequately loaded. So what do I do? You can repeat another bolus dose of 1 to 2 grams of magnesium sulfate. So you give magnesium sulfate, repeated the dose. Even after that, also there is subsequent seizures. Then you can try other anti-epileptic drugs like your benzodiazepines or levetiracetam. So this is how you manage a seizure in your patient. First drug is magnesium sulfate. If there is a seizure, even after that, you can give another loading dose of 1 to 2 grams. Even after that, if it still persists, then you can start your anti-epileptic drugs like benzodiazepines and levetiracetam. Is recommended during pregnancy. Okay, you can give this.
Sir,
Yeah.
sir, if there is a renal failure, then
So renal failure also loading dose doesn't change. I'll tell you in subsequent slide. Loading dose doesn't change. Okay, I'll tell you in the next slide. Okay, so this is the overall slide which tells you about managing seizures or eclampsia in your patient. So first one, anything if it's a CCS. So this is how you'll start. You'll start with airway, breathing, circulation, emergency first. When you see a witness seizure or this patient had a seizure, the first thing you'll look into airway, breathing, circulation. So see airway. If required, if there's desaturation, start on oxygen, open the airway, lateral decubitus position to prevent aspiration, suction the mouth and keep the airway patent, monitor the heart rate, BP, get an IV access, avoid maternal injury. That's what I told you. So she should not fall, should not hit when she has a seizures to the surrounding structures. So elevate, put bed the railings of the bed, and preferably that should be padded. So after that, so how do you prevent recurrent seizures? I told you first episode of seizures. So magnesium sulfate, loading dose 4 to 6 grams IV over 15-20 minutes. Maintenance dose is 1 to 2 grams IV per hour up to 24 hours. If no IV access, I've told you the dose already. So control severe hypertension. I told you the drugs available are labetalol, hydralazine, nifedipine. So labetalol 10 to 20 mg IV slowly over 2 minutes, followed by 20 to 80 mg every 20 to 30 minutes as the dose. Hydralazine, nifedipine are the doses. And you do some lab tests and see what is the problem. So if she has another recurrent seizure, I told you can repeat another bolus dose of your magnesium of 2 grams IV. If refractory, even after that, I told you can start them on either lorazepam or levetiracetam can be given. So what is it? So if you think that patient may have another subsequent episodes and you are sure of the maturity of the baby, then you can go ahead with definitive therapy. That is nothing but your delivery. Okay, so this is the entire flowchart for showing management of eclampsia. Now coming to, we are giving magnesium sulfate. So whenever you're giving some drugs, you should know the side effects of the drug. So what is the common side effect you see with magnesium is hypotension. We all know, I told you, it can also reduce the blood pressure. So it can cause some hypotension. So it can cause facial flushing at the injection site. So increased warmth and sweating sometimes can produce some visual disturbances, chest pain, and nasal stuffiness is also being complained. Okay. So what is the desired therapeutic level? So the blood level is 4 to 7 milliequivalents. So this doesn't mean, so whoever I'm giving magnesium sulfate, I'll be checking the blood levels. No, it is not required. But if at all you're doing it, the desired therapeutic blood level to prevent further seizures or to be kept during eclampsia is 4 to 7 milliequivalents per liter. So what are the levels of magnesium in the toxicity symptoms? So these are all the levels. I told you 4 to 7 is recommended. If it goes beyond that, so initially you'll see some ECG changes like prolonged PR interval, widened QRS. So next you'll see some muscle weakness and loss of DTR. So deep tendon reflexes are not seen. If it goes at around 15 milliequivalents per liter, they will see respiratory depression. The patient will have apnea, shallow breathing and all. At 15 milliequivalents per liter, it can cause SA node block or AV node block, and your patient can have bradycardia, heart blocks, and things like that. If it goes beyond 20 milliequivalents per liter, then your patient can have cardiac arrest. So it is very important. So therapeutic drug level is 4 to 7 milliequivalents per liter. If it goes beyond this, you can have various consequences. You should know about magnesium. You get a patient with preeclampsia or eclampsia, and you have been asked about magnesium, you'll definitely know the therapeutic range, and you should know the toxic levels and their symptoms. How do you identify these symptoms? Okay. Again, I told you what is the role of routine. So I'm giving magnesium sulfate to my patient with preeclampsia or eclampsia. Should I routinely monitor? No need to routinely monitor. Somebody asked me a question, what to do when there is renal impairment. Renal impairment, loading dose doesn't change. Only changes, you'll need to monitor for toxicity. Like either you can do for clinical monitoring or you can send blood levels and check for the magnesium levels. Okay. So renal impairment or some dyselectronetemia is there. Only then you need to monitor the magnesium levels. Otherwise, no need to monitor routine magnesium levels for everybody who's receiving magnesium. Okay. So what is the monitoring required? I told you. So no need to go ahead with any blood tests. So you can just simply monitor the deep tendon reflexes or urine output. Or sometimes you can do creatinine as well. So when do we give the maintenance dose? I told you loading dose doesn't change. Whatever be the kidney function of your patient, loading dose doesn't change. Only change occurs with your maintenance dose. When do we give the maintenance dose? So you gave the loading dose. So then I'll check for DTR, I'll look at the urine output, and then I'll decide on my maintenance dose. So I give my maintenance dose only when the DTRs are present. You did a deep tendon reflex, the reflex is still present, I can give the maintenance dose. You looked at the respiratory rate, there is no apnea or bradypnea. So the respiratory rate is more than 12 per minute, I can give this maintenance dose. If the urine output is more than 100 ml in 4 hours, then I can give magnesium. Okay. If you can check the magnesium levels, you can check and you can see if it is within the normal range, you can give magnesium. You can give the maintenance dose. If it is beyond, it's already in the toxic levels, then you don't give the maintenance dose. So you need to monitor DTR, respiratory rate, urine output, if possible magnesium levels, otherwise not required. Just clinical examination is adequate to suspect magnesium toxicity. So how do you manage magnesium toxicity? I told you with the first sign of toxicity, what do you do? If there is ongoing infusion, stop giving subsequent doses, and you need to remove this magnesium. If your patient has good kidney function, just give them some diuretics, it will get excreted in the urine. If your patient has some impaired kidney function, then there's no other choice. You will have to remove it from the body by doing dialysis. And we all know antidote to magnesium toxicity is your calcium gluconate. It's only required in usually severe cases, say mild elevation in the blood magnesium levels. It's around 7, 8, 9, and all, no need to worry. There is some heart blocks, arrhythmias, or respiratory depression. Then you should consider giving antidote. That is 10 ml of 10% calcium gluconate, which should be given over a period of 5 minutes. So this is how you manage. So stop further administration. Try to remove it from the body either by dialysis or diuretics, and give an antidote like calcium gluconate. So how do you manage an eclamptic patient after a seizure? So what do we do? So we control the seizure, we give medicines to prevent further seizures, but what am I doing with the patient? So close monitoring of mother and fetus is very, very important. And I told you, only definitive treatment to prevent preeclampsia or eclampsia is urgent delivery. Okay, so look if there are any indications for delivery, like if there is any fetal maturity is good, or there is some uterine contraction, some bleeding PV, rupture of the membranes. There are some indications for delivery, I think, and you feel the mother and fetus are safe to be delivered, you can go ahead with delivery. And you need to monitor. So maternal monitoring is very, very important after the seizure. So monitor the respiratory rate, look at the oxygenation status of the mother, heart rate, blood pressure, fluid intake, urine output, neurological status for signs of raised ICP or bleeding. Recheck the platelet count and kidney function. So maybe previous episode there was no thrombocytopenia. Now your patient may have developed thrombocytopenia. So look at what is the platelet count, what is the kidney function. Monitor the fetus also, and you can give antenatal steroids if you're planning to deliver your baby in the next 24 to 48 hours. And fetal lung maturity is a question. Then you need to give antenatal corticosteroids only for fetal lung maturity. Otherwise, normal for steroid for the mother. It's for the fetal lung maturity. You're giving antenatal steroids. Okay. What are the common life-threatening emergencies that are associated with preeclampsia? Anybody? So what are the other? I mean, we have seen a few of them already. So what are the other life-threatening emergencies you can see in preeclampsia?
Pulmonary edema.
Pulmonary edema, right? In this case, we have pulmonary edema. Next.
Press.
Next.
CV.
Yeah. So hypertension, bleed, raised ICP. So all of those are the risk factors. So pulmonary edema is most common. Even our patient had this. Okay, so hypertension, encephalopathy, which can be there because of cerebral edema or intracranial hemorrhage can happen because of high blood pressure. Eclampsia is another life-threatening illness. Another one is sometimes if the blood pressure is very, very high, the patient can have subcapsular liver rupture. Okay, so it can lead to severe hemoperitoneum, hypotension, and you may even lose the patient sometimes. So these are life-threatening emergencies which can happen in a patient with preeclampsia. Those are pulmonary edema, hypertensive encephalopathy due to cerebral edema or intracranial hemorrhage, eclampsia, and subcapsular liver rupture. So these are the 4 things which can lead to other high risk of mortality. Okay. So how do you manage mechanical ventilation in this patient? What are the PaO2, PCO2 targets? Again, whenever you intubate a patient, this will be the next question they are asked. This is a little different compared to other patients in whom you ventilate. We want to keep good oxygen levels because we need this gets transferred to the fetus. So we are worried about the fetal transfer of oxygen as well. So we'll have to keep little higher PaO2s, at least more than 67.5 millimeters of mercury. Usually it will be given in kilopascals. So it is around 70, more than 70 millimeters of mercury. And keep the PaCO2 little low, not very low, but low, around 30 to 34 millimeters of mercury, because we know if the CO2 goes less than 30, it will lead to uterine vessel vasoconstriction and decreases the blood flow there, and it can cause fetal acidosis. To avoid this complication, so don't overventilate, keep the PCO2 in the target range of 30 to 34. Don't bring it down less than 30, it will cause harm to the fetus. Next, permissive hypercapnia cannot be advocated in pregnancy. So if your patient pregnant develops ARDS, so there is no concept of permissive hypercapnia because you're going to harm the fetus. Okay. So how do you approach and manage hypotension? Say for example, you had this pregnant patient who developed hypotension. Okay, so how do you manage this? Most common it will be because of your IVC compression by the uterus. Okay, it will mainly because of aorta cable compression. So first thing what you'll do, if at all your patient maternal who's been supine or near supine and develops hypotension, first thing you'll do is you give a left tilt, okay, left lateral decubitous position, so that the uterus moves away from the aorta and vena cava, so that they won't get pressed. This is mainly significant if your patient's gestational age is more than 20 weeks. Before 20 weeks, the uterus is very small. It may not cause significant aortic compression, but if it is more than 20 weeks, it can cause significant aortic compression. First thing you do in your patient who develops hypotension is put the patient left lateral position. The uterus moves away. There's no compression of the aorta and vena cava, and it will lead to improvement in venous return, and the blood pressure usually becomes better. So other than that, you need to assess the volume status, and cautious hydration need to be given if it has hypovolemia or other causes of hypotension. So this is very important. So your patient is a preeclamptic patient. How do you manage fluids is a very, very favorite question. So you can't give, say your patient has hypotension, I can't give very liberal fluids. So there is no recommendation like how we have fluid resuscitation for sepsis. There's no recommendation exactly how much of fluid to give, how to give, and all with respect to preeclampsia, because not many studies have been done because of the difficulty in doing studies in pregnant patients. So ideal approach nobody knows, but we all know they are at high risk of developing fluid overload. This is mainly because they have there's hypoalbuminemia, there's hemodilution, there's increase in blood volume already. And if you give more fluid over that, and in case of preeclampsia where there is increased extravasation, there's more of third spacing, all of this will worsen the general condition of the patient. So be very, very careful. You should give judicious, either use assess and see the responsiveness and give small liquids and again assess. So after repeated assessment, you give fluids. Okay, don't blindly give like how we give it in any other case of hypotension. Okay, so you should be very careful. They are at high risk of developing pulmonary edema. One is because of low oncotic pressure. The other one is because of increased permeability of the vessels, especially in your cases with preeclampsia. Next, continue with the Vignan. So this patient did not have any further. So he gave magnesium, he did not have any further seizures. Oral antihypertensive medications were optimized. She was extubated with a successful weaning trial. Was shifted to the ward with NIV, so became better. So fetus was also okay, BP better, no seizure. Shifted to ward with NIV for the pulmonary edema part. During a stay in the ward on day 4 of hospitalization, she had episodes of headache and was found to have high blood pressure. There was some bleeding PV and pain abdomen. She also complained of some reduced perception of fetal activities. She was shifted to the ICU for further management. On admission to the ICU, we saw that her heart rate was 128 per minute, BP was 177 by 120, SpO2 was 92 on room air, and respiratory rate was 34. So what do you think has happened here?
HELP syndrome.
Okay, anybody else? Again, you don't have evidence for HELP syndrome, no?
Press.
Okay, anybody else? And in this, no CNS symptoms at all, if I've seen.
Okay. Abruption.
Okay. So it can still be preeclampsia, correct? There is no rule that it should not come back again. You treated it and sent it back. It is still preeclampsia for me. Anybody who wants to say no? Right? Again, you have high blood pressure. So respiratory rate is high. And we already know this case is a known case of preeclampsia. She was eclampsia also. No further seizure, so less likely to be eclampsia. But now she can be preeclampsia again, right? It still fits into a diagnosis because she's already a known case of preeclampsia. So 177, 120 is the BP. So again, this is case of preeclampsia. But one new thing you're seeing is there's some bleeding PV, some episode of headache, and high blood pressure. Pain abdomen is also there. Some perception of fetal. So maybe some signs of fetal distress. Correct. So on examination, CVS, RS, CNS was nothing. On per abdomen, there is some tenderness in the abdomen. Contractions are present. There is blood stain discharge, pleural vaginal. Okay. So what is the differential? So for me, it is still preeclampsia only. Okay, preeclampsia. So don't. It need not be a new complication, right? So preeclampsia was there, that doesn't mean it should not come back again. Still in the hospital, she's just 4 days back only. She had an episode of seizure, preeclampsia, eclampsia, severe preeclampsia already there. Now she's again, it is preeclampsia with fetal distress. There are some signs of fetal distress, so you'll have to confirm it. And there's some contractions happening, so probably in early labor because we know this patient is already 34 weeks gestation, correct? So what is the next line? Again, like you will again manage it like preeclampsia only. Start antihypertensive medication. So if she was an oral, maybe this is blood pressure is very high. So start again IV. Give magnesium sulfate, fetal monitoring, obstetric consultation. Now again, so here now also you should plan maternal delivery as early as possible. Delivery as early as possible. Again, USG abdomen. Why she's having pain abdomen? Some contractions. Is there any complication? Any rupture of uterus or placenta? Uh, uh, any abruption of the placenta? All those things need to be looked into. So USG abdomen revealed oligohydramnios, that is there is drainage, I mean the fluid is gone, anterior placenta and retroplacental clot was there. So cardiotocogram gun shows severe fetal deceleration. Doppler revealed absence of end-diastolic blood flow in the fetus. As there was oligohydramnios, unfavorable cervix and severe fetal bradycardia, she was decided to take up for emergency cesarean section and a female fetus was delivered and shifted back to the ICU. So intra-op blood loss was approximately 1000 ml. So how many of you say this is significant blood loss or that is normal? So usually this is a normal amount of blood loss. Okay, so the usually they say 500 ml in normal delivery and approximately around 1000 ml in cesarean section is okay. Okay, if it goes beyond that, it is something significant. So it is still okay. Intraoperative, the bleed was not much, but after 4 hours in the ICU post cesarean delivery, there was severe bleeding PV. So when you examined, you saw that the patient's abdomen was soft, uterus was palpable and soft, extending above the umbilicus. There were excess of blood clots in parvagina. Heart rate was 133 per minute, BP was 90 by 60, but rest was stable. So anybody wants to comment on this abdomen findings? So abdomen was soft, uterus palpable, it was soft and extending above the umbilicus, and there was some excessive blood clots which were coming out through the PV. So anybody wants to
Atonic
say?
uterus atonic.
Yeah. Yeah, so usually your uterus should have become hard by this time, correct? So it should have become hard and it should have contracted and usually don't see, I mean, you don't palpate the uterus above the umbilicus after delivery. Usually it'll shrink and come down. and it should have been hard at least. So this is not there, and you are seeing excess of blood clots coming. As you said, could be a case of PPH, and because the uterus is soft, most likely it is atonic PPH, and that could be the reason why our patient is having hypotension, because she is having a new blood loss. So what is your differential? Yes, it is a case of postpartum hemorrhage. What are the common causes? Yes, anybody wants to take this question? What are the common causes for postpartum hemorrhage?
Uterine atony.
Yes,
There is
atony.
a retention of your placental heat,
Yeah,
any
retention of
thrombin
placenta.
that causes coagulopathy, and trauma.
Correct. Correct. So these are things you all know. This is the mnemonic to remember the four T's of PPH. So tone, tissue, trauma, and thrombin or coagulopathy. Okay. So you should look into each one of them. So tone. So whether the uterine tone is abnormal, like in so atonic PPH. So uterine distension. If there was significant uterine distension before the delivery, like in multiparity, so multiple gestations, polyhydramnios was there, fetal macrosomia is there. All of these would have gone to cause significant uterine distension. Usually they don't, in a few cases, they don't return back to normal size. So that can lead to abnormality in the tone and lead to PPH. Tocolytics, precipitate labor. What is precipitate labor? Very rapid labor or prolonged labor. Very prolonged labor or rapid labor, both can lead to atonia. So prolonged oxytocin augmentation, chorioamnionitis. So if there's infection in the chorion and amnion, that can also lead to atonia. Uterine fibroids can lead to atonia. So next, you should look if there is any tissue reason, like retained bits of placenta can also lead to persistent bleed. Abnormal invasive placenta, like we know increta, percreta, acrita. So where there is adherent placenta which is adhered into the myometrium or into subsequent deeper layers of the uterus. So those can also lead to severe bleeding or postpartum hemorrhage. And if there is not complete removal of the placenta, there are some bits inside that will hamper complete closure of the venous sinuses. That can also lead to bleed. Trauma, so any during delivery, so vulvovaginal injury, cervical tear, episiotomy tear, uterine rupture, uterine inversion. So all of these can lead to PPH. Coagulopathy. So it can be any reason for coagulopathy, either pregnancy induced or do not related to pregnancy. So pregnancy conditions like your thrombocytopenia because of HELLP syndrome or DIC, and we all know in severe preeclampsia also can have some thrombocytopenia, placental abruption, amniotic fluid embolism, or your patient already had some coagulopathy that can also manifest. So these are the four T's. So always remember these mnemonics. These are little classic mnemonics. So if you tell at least two conditions in each, you will cover at least 8 causes for your postpartum hemorrhage. Again, so how do you want to evaluate this patient? So first you estimate what is the problem with uterine tone. Has it contracted? Now do uterine massage and use some medications to make it better. So check whether the placenta is completely expelled. That's what. So you know 4 T's. So now you do investigations to see if anything is the reason. So look at the tone first, or give some uterotonics. Start them on some oxytocin or ergometrin or various other drugs which are there, or see if there's any retain, do an ultrasound scan or do a manual evacuation or do a perversion examination and see if there is any retained beds. Do a speculum examination, see if there's any tear, and send them blood tests and see if there is any reason for coagulopathy. Same thing you'll be doing. So estimate the uterine tone, check whether placenta is completely expelled or not, do ultrasound, manual examination or instrumental examination, exclude any trauma along the genital tract, do a cross matching, send emergency tests, full blood count, coagulation profile, ABG, and you can do some viscoelastic tests like ROTEM or TEG, which will give you a better idea of what is happening. If the tone is the problem, then you should start these patients on uterotonic drugs. Okay, you need to read about those uterotonic drugs. So next, so after when all of this is happening, I did this investigation. So we got this hemoglobin was 7.8, on admission it was 10.2. So usually in pregnancy there will be hemodilution, even though 1 liter of blood loss has happened. Usually the hemoglobin won't fall very significant because the body is already prepared for that amount of blood loss, and usually the hemoglobin is pretty stable. There is hemodilution, we all know it. Total counts was 21,000. PT was 22 seconds. Normal, we all know, is 15 seconds. INR is 1.8. APTT is 34 seconds. Fibrinogen is 110 milligram per deciliter. Platelet count is 78,000. Ultrasound examination showed there was a large uterus with few blood clots internally. No, you did a speculum examination or manual examination. There was no injuries to the genital tract. Uterus contracted post-uterotonics. You gave some uterotonics. Then after that, the uterus became better. So what is then this blood counts? Anything to comment? So what are you seeing? What are the abnormalities in this? So HB is low, total counts is elevated, PTINR is deranged. Platelet count is low, and fibrinogen,
It's low.
Less.
yeah, fibrinogen is low. Okay, so what do you think it is? So this
DIC.
original diagnosis for bleeding is this patient had atonic PPH, but this patient was in the ICU, was there for 4 days. You managed, and now some bleeding PV is there, some uterine contractions is there, some retroplacental clot was there. So possibility of DIC is also there, and sepsis and coagulopathy can also be the reason. So why this abnormal bleeding parameters is one atonic PPH, lot of blood loss might have happened that can also lead to, or it can be because of DIC, or sepsis and coagulopathy is also a rare possibility. So this is something known as your DAC score. We all know ASTH, that is Society for Thrombosis. There is a DAC score. There is some modification for the pregnancy-induced pregnancy DAC. So these are the parameters. You know, the platelet count, the PT ratio, prolonged PT, fibrinogen, fibrin degradation products. You remember the score, you can score and tell. Otherwise, in the exam, they usually ask you a score. If you know there is something called a DAC score given by ASTH, there are a few other scores as well. That is one of the scores you should remember. And there is a modification during pregnancy. Okay. So you can put those score, your patient will come very high. So this is probably a case of DIC. So how do you manage DIC in this patient? So cornerstone is resolution of underlying conditions. So what was the cause? So there was some bits of placenta retained. So retroplacental clot was there. So something which was there. So remove it. So if there's some infection, give some antibiotics and make attempts to stop the bleeding, stop further bleeding. Worsening DIC, plan delivery, and if the baby is still not delivered, so deliver the baby. Team-based approach, involve multidisciplinary involvement, intensivist, obstetrician, neonatologist, hematologist. Appropriate blood component if there's active bleeding. Otherwise, don't give any blood product, even though if the parameter shows are abnormal. If there's no ongoing bleed, don't correct the parameters. Okay. If there is bleed, then identify what is it by doing a viscoelastic test and replace the particular blood component. Bleeding persists if the initial surgical measures have failed. So this patient plan either hysterectomy or major pelvic blood vessel embolization or ligation can be planned if it persists even after delivery. Okay. So next, what is the role of tranexamic acid? Yes, there is indication. WHO also recommends to give IV tranexamic acid, especially in a case, say for example, there were some risk factors in your patient. There was polyhydramnios, a mega baby, or multiple gestations, or there is some tear during delivery, this prolonged labor, the uterine tone is not good. So then you can prophylactically give tranexamic acid. This is a recommendation. They ask you to give within 3 hours of birth in any case of clinically diagnosed PPH. What is the recommended dose? At least 1 gram or 15 mg per kg is the dose. There's a trial. So if they ask for evidence, there's a trial called Women Trial. In this 20,060 parturients were included. Most of these patients were from the developing countries, around 90%. And what was the finding of the study? They gave tranexamic acid to prevent PPH, and they found that so there was mortality benefit. Okay, so there was death in those patients who developed PPH in whom tranexamic acid was given had significant reduction of mortality. They did not die much. Okay. So after all of this, all the resistive measures happened and the attempt to stop bleeding, there was no significant improvement. She continued to bleed. So there was worsening hypotension even after adequate resuscitation, inotropes, coagulopathy, and other organ system functions started to worsen. With ongoing measures, patient had a cardiac arrest. So what is the first question? So what are the causes of cardiac arrest? Anybody? You all know the 5HS and Ts.
40,
Yeah,
48.
yeah. 5HS, 5Ts is one. Apart from that, there is another new mnemonic for cardiac arrest in pregnant women. This is given by American Heart Association, which was given in 2015. So for pregnant patient cardiac arrest, you should remember this new mnemonic, that is A to H. I mean, this also has similar to your 5HS and 5Ts. So these are the things. What are those A to H? A is anesthetic complications if it happens during anesthesia, or it can be because of accident or trauma. So that can lead to cardiac arrest. Bleeding, cardiac causes. Okay, so any cardiac complication which happens during pregnancy that can lead to cardiac arrest. So drugs, embolism, it can be amniotic fluid, it can be pulmonary embolism, any embolism, fever, general causes like hypoxia, some electrolyte disturbances, and hypertension. So this is A through H mnemonic for cardiac arrest, causes of cardiac arrest during in a pregnant patient. So how is CPR in a pregnant patient different from a non-pregnant? Anybody? How is it different? So what are the things you do differently if it's pregnant?
Left lateral displacement.
Yeah, very good. So you should do a left lateral displacement so that aortic cable
Sir,
compression is not improves
during
velocity.
CPR, it is left lateral position during resuscitation, but maybe in
Yes.
CPR patient in the flat and another
No, no,
person
no,
is
no.
help me to left
Okay.
lateral uterine displacement.
Mainly what we are trying to do is you are displacing the uterus from the aorta and vena cava. So either you can give a wedge beneath the right hip and displace it and do the CPR. It will not hamper the CPR because you are giving the under the right pelvis. Okay, you are doing CPR high above. So or you can do a manual displacement. One of them is also okay, but you need to do a displacement. Okay, so the uterus should be pushed away from the aorta and vena cava. Next,
Emergency
anything else?
cesarean. Emergency cesarean
Okay.
within 4 minutes.
Within 4 minutes of perimortem, if the mother dies, I mean, not able to resuscitate, not able to bring back ROSC, then you should do within 4 minutes. Next, of
And it will be the 5 minutes, the time for the delivery of the fetus.
5 minutes. Yes, five
Total,
minutes is the
total nine
delivery as
minutes.
per AHA recommendation. Okay, few books give 4 minutes, but AHA recommendation is 5 minutes. Okay, next. Anything else is different in CPR? Okay.
Uh,
There are a few more. We'll see the complete differences. So these are the differences. So in this, so who are the people who are affected? It's only one person in a non-pregnant patient, whereas in a pregnant patient, both mother and fetus, two lives are involved. Chest compression, no difference. So, okay, it is lower third of the sternum, doesn't change. Airway, we all know there is difficulty in airway. So no nasopharyngeal airway because it will cause severe bleeding. And you, if you are planning to intubate your patient for a definite airway, insert endotracheal tube, which is 1 millimeter smaller than the usual size. Intubation can be difficult, so always get an expert for intubation. Don't wait early intubation, okay, because there's high risk of regurgitation, aspiration, and high desaturation. We have already seen. Correct. Next, breathing. We need two persons because there will be some amount of resistance. It will bag mask ventilation will not usually be easy. If it is better, you have two people, okay, for oxygenating the person. And we all know pregnant patient is more prone to hypoxia than a non-pregnant because of reduced FRC, all of that. So don't hyperventilate also because I told you already, it will reduce the blood flow to the fetus and it can result in fetal acidosis. Defibrillation, no difference. Same amount of shock, 200 joules, 200 joules. IV axis, this is very important. You should take an IV axis above the diaphragm. Okay, don't put a femoral IV axis and do resuscitation. Always have IV axis above the level of the diaphragm. The main problem is if you put below diaphragm, your drug may or may not reach the heart. So for that reason, the recommendation is to put IV axis above the anywhere above the diaphragm. You can put it in any of the limbs, IJV, anything is fine. Okay. Other than that, left uterine displacement should be considered. Okay. So how do you perform left uterine displacement? So manual LUD is optimally performed by a provider on the left side. You stand on the left side and with your two hands, pull the uterus to your side. The uterus is pulled leftward and upward towards the ceiling. It may be applied from the right side of the patient. So either you can stand on the right side and push to the left side or stand on the left side and pull towards you. Or you can put a wedge beneath the right hip, at least a height of 1.5 to 2 inches is the recommendation. So I'll show you the pictures. See, this is how you do. Stand on the left side and pull the uterus to the left side, or stand on the right side and push from the right side, or you can put a wedge beneath the right hip, at least to the height of 1.5 to 2 inches. Okay, this is how you do a uterine displacement. Any pregnancy, you should know this. Okay. So when do you perform? The recommendation is 5 minutes. If no ROSC is achieved within 5 minutes of CPR, then within 5 minutes you should deliver the patient. So this is the AHA 2020 algorithm. I just highlighted when to do perimortem. Otherwise, the rest of the things are almost same. So you can see here. So if they ask you what are the potential etiology for maternal arrest, you should say that A, B, C, D, E, F, G, H. Okay. So you can keep that 5H, 5H, 5Ts also, but before that, pregnant patient specifically asking, you should tell this A, B, C, D, E, F, G, and H for the cause of cardiac arrest. And perimortem delivery is 5 minutes. Few books give 4 minutes also, but AHA 2020 recommendation is to do the delivery within 5 minutes. Okay. Okay, any doubts in this topic? I have tried to cover almost every important topic in obstetrics. Very easy scoring topic. Okay, and few of the things which are missed here will be covered in CBS also. Very high scoring module. So you should not, if you get a case, you should be happy that you can do it easily. Okay, any doubts in this particular CCS? If no doubts, we'll go to the subsequent CCS. Okay. We can still have, you have any doubts, we will discuss at the end as well. So without wasting much time, let us go to the next CCS. So this is a 20-year-old girl who is found immersed in nearby water body by her friends. She is rescued by them within 10 minutes. CPR was administered for approximately 1 hour at the scene and during transport to the hospital as well. So she was intubated by the emergency personnel during CPR. On arrival in the emergency department, her GCS score was 3 and rectal temperature was 31.2 degrees. She was continued resuscitation in emergency department as she was still in cardiac arrest. After around 20 minutes, she was revived. So 1 hour there and now another 20 minutes, and she was revived after that. Post revival, she was shifted to the ICU. So what are the challenges in CPR? So what do you think are the challenges in CPR in a drowning patient? Yes, anybody? So CPR, we know the challenges. So in a drowning patient, obviously we all know first thing, the first recommendation in any case as per AHA during CPR is first safety of yourself, correct? So
Yes, sir.
safety of yourself. Next, do not start CPR in the water. We all know if the surface is not firm, then whatever chest compressions you do will not be effective. So need not do start CPR in the water. CPR should not be of compression only variety because we all know drowning, the cause of cardiac arrest is mainly respiratory, correct? So it should not be a CPR, chest compression CPR only. Whenever possible, you should give the breaths as early as possible or start chest compressions and do give breaths. Okay, you can't do only chest compression CPR. The outcomes will be very bad, especially in case of drowning and cardiac arrest. Okay. Immediate intubation by emergency personnel. Avoid all active attempts to force the water out of the place. Sometimes they attempt to bring out the water, they do abdominal thrust and things like that. So don't do all of that because that will worsen. It will not bring out water which is there in the lungs. Instead, it will worsen. It will cause regurgitation and aspiration of the stomach contents, which will worsen the patient's respiratory status. So don't do any attempts to bring out water. Okay, and usually start your CPR with 5 rescue breaths and then chest compression if at all possible. I mean, what I'm trying to say is don't just do chest compression. Don't just concentrate on chest compression. At any point of time, do think about rescue breaths. Okay, it's very, very important. So do not stop the resuscitation of hypothermic drowning victim. So it is like in this particular case also, it has been 1 hour, 20 minutes. So why are we giving so much of CPR? Not required. You would have already been dead. No, it is not true. They have seen in hypothermic drowning patient. If it is normothermic, then there are high possibility that you need not continue the CPR after so much of time. Whereas if it is hypothermic CPR, the victim's brain is hypothermic, so it is well protected. So you should continue your CPR for a longer duration. Okay. Next, coming to what are the challenges in hypothermic patient. So we saw challenges in drowning patient. So what are the challenges in a hypothermic patient? So whenever you're checking for a pulse, so you should be a little more patient because usually when the hypothermia is very, very severe, you'll have very profound bradycardia, sometimes 10 beats, 20 beats per minute and all. So if you just check for 10 seconds, you may be missing a pulse. Okay, so you may think that there is cardiac arrest, no pulse, and you may start CPR. But remain patient, especially in a hypothermic patient. When there's severe hypothermia, just palpate for a little longer duration for because they'll have very bad bradycardia. Okay, next, resuscitation should be attempted on all patients. CPR should continue until the patient has rewarmed to at least 35 degrees. So continue CPR, at least the patient's temperature becomes 35. Use the same ventilation chest compression ratio that doesn't change. So 15 to 2, 30 to 2 should be continued irrespective of the thing, and mostly this drowning is common in pediatrics, so the ratio should be 15:2 in them. Okay, so defibrillation is unlikely to be effective below 28. So you took out the patient, the patient's core temperature is 28, then you try attempting defibrillation will be of very, very less help. So, and even your CPR should be continued till your core temperature comes to at least 35 degrees. Drug metabolism is significantly slowed, and between 30 and 35 degrees, if you're giving adrenaline, you should give half the usual rate. Okay, so that is the recommendation with respect to hypothermic patient. So what are differences? So initially there used to be assumption that seawater, salt water, there'll be a lot of differences and all, nothing like that. So no significant difference in the electrolyte abnormalities or degree of lung injury. So whatever be the osmotic gradient. So they thought osmotic gradient, seawater, there'll be movement of water, dyselectrolytemia can happen, fluid shift happens, all of that, nothing like that. So there's no difference. Only thing is the bacterial burden will be different. So seawater has less amount of bacteria compared to a fresh water. So if somebody is there in a fresh water, dirty pond and all, so they will be at high risk of bacterial aspiration than somebody from the seawater. That is the difference. Otherwise, no difference in your electrolyte or osmotic gradient related things. Okay, what are the common ECG changes in hypothermia? We all know, I told you, bradycardia is there. What is Osborne waves? It is seen in lot other conditions, but is characteristically seen. Correct.
J point
A
elevation.
point elevation, which is seen. So Osborne waves, hypothermia, a lot of the conditions also you can see them. QT prolongation can be there. Shivering artifact. So if shivering is there, you can see some artifacts. Apart from that, if there is extreme case, you can see ventricular tachycardia, ventricular fibrillation, or cardiac arrest. So these are the common ECG changes which can be seen in your patient with hypothermia. Then what issues may come during airway management in drowning? So laryngospasm may occur. So even during drowning also, so when the amount of water enters into the larynx, so it will precipitate, it will cause laryngospasm, or it can happen even during your so laryngospasm can be there in your patient with drowning. They are at high risk of aspiration, right? So there is high risk of aspiration. Next is these patients are at hypoxemia because there is lung which is filled with water, so there is no gas exchange happening. So these patients are at risk of hypoxemia. So apart from general critical care, what are the things you should be evaluating? You should always look for trauma. So we don't know how this has happened. It can be because of diving injury or whatever has happened. So you should consider them to have trauma, or you suspected him to have trauma. Like how you evaluate a case of trauma, do primary survey, secondary survey, and look for what could be the possible cause for them to drown. Usually it will be hypoglycemia, anybody having a seizure and fall into water and can get drowned, or drug or alcohol injection when the conscious level is very low, or so this patient after fall may have a marine envenomation. So any marine organism can, any animal can have a envenomation, can bite. So all these are a possibility. You should look into all of these. Okay. Continuing with the Vinay, she was continued in close observation. Her vitals were 80 per minute, BP was 100 per 70 millimeters of mercury, even without any vasopressors. SpO2 was 92% on ventilator support. FiO2 was 0.75. She's comatose. GCS is E1 VTM1. Temperature is 35 degrees. She was being started on RT feeds and urine output is okay. Her chest X-ray shows bilateral pulmonary infiltrates. What are the principles in management in ICU? So this usually doesn't change much. So like how you monitor your any other patient admitted to the ICU, all those principles should be continued here also. Ventilation, if you are planning, so you should give a lung protective ventilation with high FiO2, high PEEP of around 12 to 15. Investigation of possible aspiration with chest X-ray and ABG, because we know this patient can have aspiration and there is a risk of them developing infection. Can do a chest X-ray to know how bad it is, blood gas to know the gas exchange and all. Establishment IV access, correction of hypovolemia, assessment of the temperature and rewarming should be done. Bronchoscopy and suction as indicated by copious aspirated medicine. So based on, say, if you during a resuscitation, if the patient regurgitated, vomited, and there is possibility of aspiration, then you can try to remove it by doing a bronchoscopy. Orogastric tube should be placed to relieve gastric distension. If there's significant amount of distension of the stomach, so that will impair your ventilation, so impair further care, and it can result in regurgitation aspiration. So you need to put a orogastric tube and decompress the stomach. What are common organisms which can be aspirated during drowning? These are all the list of common organisms which can be seen, which can be aspirated during drowning. Those are Aeromonas, Pseudomonas, Proteus, and Burkholderia pseudomali. So what is the role of antibiotics? This is very commonly asked question. No role for routine antibiotics. Though, sir, this is aspiration, lungs can get contaminated. There are some organisms in the water. So no role for routine prophylactic antibiotics. No. Only you'll consider if the person's drowning is happening grossly contaminated. It's a dirty water. So it is grossly contaminated. So then you can consider antibiotics. Otherwise, no need to give routine antibiotics for all the cases who come to you with drowning. Say, for example, most of the times these patients will develop, initially it will just be a pneumonitis, but these patients after 2 days, 3 days stay in the hospital, they'll develop some new infection. There is usually a hospital acquired infection. In that case, you can give antibiotics, but at the time of admission, if there is no gross contaminated water aspiration or no evidence of aspiration of the gastric contents, then no need to worry about it. No need to give prophylactic antibiotics. Is there any role for steroids? No, there's no role for steroids. Okay. So name some complications which can occur due to drowning. I told you one of the most common complications is laryngospasm. I told you especially pneumonitis can happen. It's not pneumonia still. It can still be pneumonitis. Negative pressure pulmonary edema can happen because your patient has laryngospasm, cords are closed, attempting to breathe. There is negative pressure pulmonary edema. They can develop ALI or ARDS, that is acute lung injury or ARDS can happen. Arrhythmias can happen. Hypoxic ischemic encephalopathy. There is no gas exchange. There's severe hypoxia, and we all know brain is very sensitive to oxygen. So less oxygen going to the brain. They can have hypoxic ischemic encephalopathy. Dipped in cold water, there is high risk of your patient developing hypothermia. Electrolyte disturbances can happen. And due to the fall, say they dived into a pool, had head injury, so associated trauma can also be there. So they can have traumatic brain injury or spinal cord injury is also possible. These are all the common complications you can see in your patient with drowning. So how do you manage ARDS in this patient? Same criteria doesn't change. So consider lung protective ventilation, low tidal volume 6 ml per kg, higher P plats are less than 30, permissive hypercapnia. So what are the treatment options for refractory hypoxemia? Again, no difference. So prone ventilation, ECMO, however you manage your regular case of ARDS, refractory hypoxemia, you can manage in the same way. How will you decide for IV fluid replacement of this patient? Judicious fluid resuscitation, negative fluid balance. So, just like your sepsis resuscitation, give judicious fluid. This patient is drowning, there is water, so I'll not give water. No, not like that. So, you need to give IV fluids, correct your adequately resuscitate your patient. And once they resuscitated, you all know the need for de-resuscitation. Consider negative balance after 48 to 72 hours once the person's hemodynamics and organ functions are better. So continue with the case. On day 3, her vitals are heart rate of 78 per minute, BP of 112 by 67, SpO2 of 94%, and the FiO2 was 0.5. She still remains E1, VT, and M1. So pupils are 3 mm reacting equally. Plantas are mute. So hemoglobin is 11.2. Total counts are 13.3. Platelets is 1.35 lakhs. Sodium is slightly low, 129. Potassium of 5.2. Calcium is low, 7.6. Chlorine 101. Urea 34. And creatinine is 1.5 milligram per deciliter. So what are the differential diagnoses for a poor neurological status? So any patient with drowning comes to you, low GCS. What are your differentials? That's what they're asking. So here we know drowning can cause hypoxia. So it could be a case of cerebral anoxia or hypoxic ischemic encephalopathy. There can be decreased response because of hypothermia. There could be have been a head injury. I told you a diving accident or motor boat accident in the water. So possible. So head injury is a possibility. Or there can be severe cerebral edema. Hyponatremia can be the reason. So septic metabolic encephalopathy can be there, or sometimes non-convulsive status epilepticus can also be there. So these could be one of the reasons why your patient's neurological status is poor. So how do you evaluate? So these are our differential causes. So to confirm these, we should do specific investigations like MRI, brain, EEG. Usually you do a CT scan first. If you can't find out anything and you're suspecting something, then you can do MRI brain. EEG tells any seizure activity happening or activity, whether there is any activity happening. Liver function test, serum ammonia, lumbar puncture if no contraindication to know what is the cause for your low GCS. So what are the different strategies employed to prevent further neurological injury? So this patient has low GCS. How do I prevent further neurological worsening? Avoid any further episodes of acidosis, hypoxia, and hypercarbia. That is, maintain normoxia, normal acid levels, and normal carbon dioxide. Optimize the circulation. Actively rewarm to core temperature of 34 degrees or passively rewarm over 34 degrees Celsius. If post cardiac arrest, maintain hypothermia or at least more than 24 hours. Mainly don't uh, treat fever or prevent fever. So if there are seizures, give benzodiazepines. So this is how you prevent seizure, prevent hyponatremia, prevent hypoxia, prevent hypercarbia, and maintain normal temperature, avoid fevers. So that is how you will prevent further subsequent neurological injuries. So, what are all the factors in a case of drowning which are associated with poor neurological outcomes? So, if the immersion is more than 5 minutes, a delay in CPR. So, if there is delay in CPR for more than 10 minutes, so you saw the patient drowned, and by the time you could start CPR, if it is more than 10 minutes, usually they have a bad neurological outcome. So GCS of 3 and fixed dilated pupils on admission. So that you brought this case, and by the time medical help arrived, you see that the GCS already at the time of presentation is very, very low, and the pupils are dilated and fixed. And there is severe acidosis with the pH of less than 7.05. or you did some neurological examination, you found that the GCS is less than 6 and abnormal brainstem function is there after 48 hours. So all these are factors which will tell that your patient will have a poor neurological outcome following drowning. So what are the poor prognostic markers of hypoxic damage on the EEG? So these are the, when you do an EEG, what are the poor prognostic? This is all similar to your cardiac arrest and outcome. So if you see theta activity, diffuse slowing, burst suppression, alpha coma, or absence of N20 response on the SSCP, so these are all poor indicators of, are indicators of hypoxic damage or poor indicators of having a bad neurological status. So continue the VNet. So MRI brain reveals effacement of sulci with features of raised ICP. So it was all because of cerebral edema. So and EEG shows some severe burst suppression. The clinical condition remains same with no apparent neurological recovery. So should this patient be evaluated for brain death? Anybody? Do you think she should be evaluated? Still, she had some pupillary reflexes and all, and we don't have no, and there is no evidence of irreversible brain damage. Correct. So no, you should not be evaluating this case for brain death declaration. Okay. So we all know what is the prerequisite for brain death declaration. So is the brain death is the absence of clinical brain function when the approximate cause is known and demonstrably irreversible. So you should have a cause which is called severe brain dysfunction, and that should be irreversible. And you can have some evidence with clinical or neuroimaging evidence of an acute CNS catastrophe that is compatible with the clinical diagnosis of brain death, or exclusion of complicating medical conditions that may confound the clinical assessment, like no dyselectrolytemia, acid-base disturbance, or electrolyte disturbance, or endocrine disturbances, no drug intoxication or poisoning, and the core temperature should be more than equal to 32 degrees Celsius. So these are all the prerequisites. But our patient still had some, some pupillary reaction was still there, and we have not proven this case to have irreversible brain damage. We don't, so it is not, don't consider brainstem declaration in this particular patient. So what should be a further management? So this patient is on the ventilator, having low GCS. You are working up for it. So how do you manage this patient? So there is need for mechanical ventilation because the GCS is low. So you will plan early tracheostomy, maintenance of other vital organ functions, prevention of secondary infections, adequate nutrition, physiotherapy, DVT prophylaxis, and prevention of pressure sores and contractures. So how will you counsel the family? So you need to counsel this patient that she'll be on the ventilator for a long time. So and her GCS is not improved, though her life is saved, but her because of the hypoxic injury which has happened during the resuscitation or during the drowning episode. So she is gonna take some time. So what will be the how do you counsel the family? It should be empathic discussion. Explain the risk factors which has led to her poor neurological status. Chances of poor neurological status and further planning as diagnosis is not sure. Prolonged duration of ICU stay is expected in this particular patient, that needs to be told to the family. And all of this, whatever is discussed, whatever you have prognosticated, all that needs to be documented. So this is the flowchart. So how do you approach a case of drowning? This is how you approach. You know, there is a grading system for this. There are 6 grades. All of you can see this 6 grades. So grade 1, 2, 3, 4, 5, and 6. Okay, this is how you see. I'll tell you how to go about it. So you have a case of drowning. So check for the response to verbal and tactile stimuli. So once, say like how we do a case of cardiac arrest, and after ROSC, what do we do? First thing we do is assess for the neurological status. Okay, same thing here also. First thing you'll do is tactile stimuli. You look for any verbal or tactile. So you give some, you talk to the patient or give a tactile stimuli and see what will happen. So if you see that yes, the patient is first we'll go with the good part. So yes, the patient is responding. So that means there is no brain damage. So perform pulmonary auscultation. So after you see that yes, the patient is responding to your command or responding to your pain, so he's made that means that the brain is okay. Next thing what you'll do is you'll do a pulmonary auscultation. That auscultate the chest and see. You see that the auscultation is normal. So and your patient has no cough, is not coughing much. That means no need to worry about him. You can just ask him to go home. Okay, the survival chances in him is 100%. So next, so you did pulmonary auscultation, but you found that this patient is occasionally coughing. So there may be some aspiration has gone into the lungs. Aspiration water during drowning has gone into the lungs. So grade 1, this is called grade 1. So what do you do here? Advanced medical attention and oxygen should not be required. So usually these patients usually doesn't require much. So no need to admit, no need to observe and all. So some cough is there, that's all. So no need to worry about them. So you can send them home actually if there are no comorbidities. But if the patient is either has some significant comorbidities, maybe you can admit in the ward and monitor this patient. So next, coming to say you did a pulmonary auscultation, but you found that there are some rails, some reduced air entry and all, something like that is there. So then that is something significant. So you see there is Krebs in the field, in most of the field, in a few fields, then it is grade 2 of drowning. So you need to give some oxygen to your patient. So you can maintain them in emergency department, observe them for some time. And once the oxygen requirement is not there, you can send them home. Usually the survival is around 99% in these particular patients. Coming to auscultation, on auscultation, you see rails, but it is there in most of the fields, which means that there is some pulmonary edema in this particular patient. So, what do you do after that? So, you need to see what is the blood pressure. So, if the blood pressure is normal, that is grade 3. So, and you need to give oxygen, correct? Your patient has pulmonary edema, so definitely you'll have some hypoxia. So, you give him some oxygen, so whatever is the source. So, if your patient has hypotension, then it becomes grade 4. So, you need to give oxygen and correct the shock resuscitation of the patient. If required, start vasopressors. And all of these patients above grade 2, that is grade 3 to grade 6, should be admitted in the ICU. Okay. So what is the survival chances in grade 3? It is 95 to 96% survival. In your grade 4, the chances is 78 to 82% is the survival. Okay, this is about patient who responded to verbal stimuli. So this is what you do. So for example, you give a verbal stimuli or a tactile stimuli and your patient is not responding. That means his brain has got affected. There is some hypoxic injury to the brain. So what do? So open the airway. So he's not definitely unconscious, not maintaining the airway. So open the airway, check for ventilation. So perform pulmonary auscultation. If not breathing, give 5 initial breaths. As I told you, give 5 initial breaths because this is a case of drowning. Respiratory is the cause for your cardiac arrest. Give 5 initial breaths and then start CPR in your patient. Okay, you gave 5 breaths and you saw that the pulse is present. So it is only some decreased responsiveness, but the pulse is present. So no need for CPR here. So it's a grade 5 drowning. So start artificial ventilation. Respiratory arrest is usually reversed after a few imposed breaths. So usually when you give those 5 rescue breaths, usually they start breathing. Only thing is they'll require some amount of oxygen or maybe some respiratory support like NIV or HFNC. So usually they'll maintain. Or if they're still drowsy, you may have to intubate your patient for the airway maintenance if they don't respond after the initial breaths. So this is grade 5. So usually the survival chances is 56 to 69%. That means there is mortality rate of around 31 to 40% approximately. So after that, you saw, he did not respond. Pulse was also absent. So what do? If the submersion time is less than 1 hour, no physical evidence of death, then it is grade 6. Do CPR, ABC, all of it. So the survival chances is only 7 to 12%, and this is grade 6. So say, but pulse is absent, but the submersion time is more than 1 hour. You saw that the patient is in the water for more than 1 hour, or there's already some obvious evidence of death, like there is rigor mortis and things like that. So then you consider this patient as dead and no need to do much about this case. So this is how you evaluate. This is a complete flowchart. It's pretty old, but there has not been any recent updates on how to resuscitate or how to manage a patient with drowning. Okay. So that's the end. So any doubts in this?
Sir, can you explain about the CPR course in case of hypothermia, about defibrillator, drugs? Again, repeat.
Yeah, I'll repeat that once again. So in hypothermia, I wanted, right? So this is the one in hypothermia. So I told you there will be significant bradycardia in these particular patients. So you should not auscultate for short duration and say there's no pulse and start CPR. You wait. You need to auscultate for a little longer time or palpate for a little longer time for feeling the pulse. So usually they'll have profound bradycardia. So don't jump and start CPR too early. This should be attempted in all the patients. So I told you usually there is hypothermia, so they're well preserved. Okay, so usually they have very good outcomes. So say 10 minutes over, 20 minutes over, half an hour over, and 1 hour over. Should I do CPR? Not like that. So you should attempt CPR on all of them. Okay. So CPR should continue until the patient has rewarmed to at least 35 degrees. So try rewarming the patient, bring his body temperature to at least 35 degrees. The recommendation for this temperature is the core temperature. So they usually recommend to put a esophageal probe, put a temperature probe into the esophagus and document the temperature. If you don't have facilities for esophageal probe, but it is difficult to insert, you can even monitor the tympanic membrane temperature. It should be brought up to at least 35. Till then, you continue CPR. Next, use the same ventilation chest compression ratio. I told you there's no change in ventilation compression. Only thing is you need to concentrate on ventilation. So don't practice. Same ventilation chest compression. So 30:2 should be continued here also. Defibrillation is unlikely to be effective below 28. So you should bring the temperature, because it will not be effective if you give a defibrillation shock if the patient's temperature is less than 28. So bring the temperature to more than 28 and then provide a defibrillation shock. Only then it will be of help. Next, drug metabolism is also significantly stored. So no resuscitation drugs will work if the temperature is very, very low. Correct. We all know body, homeostasis happens, or any drug works, or any organ in the body or any cell in the body works if there's a particular temperature range. Okay, if it is less than 30 degrees, nothing will work. So no use giving any drugs. So at least bring the temperature to more than 30 degrees, only then you consider giving any drug. If the patient's temperature is 30 and 35 degrees, if you're giving adrenaline during CPR, that should be given half the dose. You don't require the full dose of your adrenaline. Okay.
Okay.
Okay, there is one, I think 2015 AHA recommendation on how to do CPR in drowning patients, but nothing much is there in that also. Okay, so there is nothing significant in that.
Half the usual rate, in the sense like 1 mg every 6 minutes.
Which one? No,
Half the
yeah,
usual
either you can give.
half the usual rate means it is like
Correct, correct.
1
You
mg
don't give
every
it every.
3
You
minutes.
don't give it that frequently. Yeah, you'll give it double. So maybe after 6 minutes.
6 to 10 minutes, double the
Yeah,
interval.
correct, correct. So you'll double the interval, because this drug is going to stay in the body for a long time. So you give it little later, because it
And
will
there
not
is
be.
any recommendation for when to stop the CPR, but how many times, other than rescue or the fatigue or
No,
anything
no,
else?
nothing specific. That's what I told you. You could continue for a little longer time if it is hypothermic patient. So you can give it for a little longer time, because they have found that the outcomes are better. But other indications, like there is obvious signs of death or exhaust. I mean, there is the rescuer gets exhausted. All those remain the same indications. Or till your medical help comes. Till then, you will continue CPR. Okay. So we'll now go into the CBS part. So how was the CBS?
Yeah, nice.
Yes, okay. So I thought you'll say, I intentionally made it a little tougher, because few were little easy questions, but few ones were a little tougher. So as I told you, I wanted to cover all the key topics or key questions which can come in this particular topics. So we'll go into the CBS module. So now it will be very interactive. Okay. So we finished the major CCS, because it is very difficult in CCS to spend so much time. So we made it less interactive. But now I'll not move the slide till somebody answers. Okay. Yes. So it's a first one is a 63-year-old male patient, recently diagnosed with carcinoma prostate, was referred for prostatectomy to your institute. He had altered sensorium, pain, abdomen, and constipation since 2 weeks. So there is also history of back pain. You can all see the slides, right?
Yes, sir.
Okay. So there was history of back pain, which was said to be due to spine mets. Also complaints of excessive urine output since last 3 days. So ECG shows normal sinus rhythm. There's some shortened QT interval, otherwise nothing significant. On examination, he looks dehydrated. Heart rate is 90 per minute. BP is 132 by 77 millimeters of mercury. SpO2 is 97% on room air. Systemic examination shows CVSR is nothing significant. Per abdomen, there's some distension, some diffuse tenderness, he says. CNS is drowsy but arousable. Labs, hemoglobin is 11.3 gram percent. WBC is 16,000. Platelets were 2.3 lakhs. Creat was 2.1. Baseline was 0.9. Sodium was 131. Potassium 4.8. Magnesium is 2.1. Calcium is 3.32 millimoles. Converting it to grams per deciliter is 13.3 grams per deciliter. Phosphorus is 4.1 milligrams per deciliter. Liver functions were done. There is normal, and there was some hypoalbuminemia, which is 2.2. So what do you think is the case? So this is a case of CA prostate, a 63 male, and there is some altered sensorium, pain, abdomen, constipation of 2 weeks. So there's some spine mets, excessive urine output 3 days. So shortened QT interval, some dehydration.
Hypercalcemia.
Okay. So why
Physical
hypercalcemia?
hypercalcemia may be due to the malignancy in this case.
Okay. So yeah, malignancy related hypercalcemia, that is one of the emergencies. You can all see the calcium levels is 13.3. What is the normal calcium level?
8 to
8 to 10 milligram per DL.
Yeah, 8 to 10 to 10 grams per deciliter is the normal calcium levels. So anything else which is significant in this? What is the importance of hypoalbuminemia in case of
Yeah, the
hypercalcemia?
corrected calcium will be
Yeah, so
more,
corrected
it's
calcium will
about
be more
more
than
than
this,
40.
correct?
40.
Right. So that is the importance of this. So how do you manage? So we'll see in this. So what is the differential diagnosis? Yeah, all of you are right. Hypercalcemia, mainly malignancy related. So you all know the things. So these are the calcium levels based on the level of calcium. I told you. So usually the cutoff is 8 to 8.8 to 10 or 8.5 to 10.5. So based on various labs, it varies. So beyond that, it is hypercalcemia. So it is mild, moderate, and severe based on the levels. So mild is 10.5 to 11.9, moderate is 12 to 14, then severe is more than 14. So based on the levels, you have the symptoms. Mainly you see symptoms in the cardiovascular, gastrointestinal, renal, some neuropsychiatry and musculoskeletal. You all know this mnemonic, I think, correct? Bones, stones, groans, moans. Correct. There is fractures, there are stones everywhere because of the calcium deposition. Groans, that is pain abdomen is there because of either ileus or constipation, and moans because and there's altered sensorium as well. So this is the mnemonic to remember the symptoms. So what do you see specifically on CVS? You see shortened QT interval, some ST segment depression, prolonged PR interval. In GIT, constipation is very, very common. There is loss of appetite as well. Renal, there is some polyuria. Psychiatry or neuro symptoms, you see there is some depression or anxiousness. When it is moderate level, that is around 12 to 14. There is shortening QT interval, ST depression, PR interval, all that remains same. Apart from that, you start having nausea, vomiting, some loss of weight, dehydration is there. There is some hyporeflexia, loss of consciousness can happen, weakness can happen. When it is very severe, you see some arrhythmias, ventricular tachycardia, fibrillation, cardiac arrest can happen. There is acute pancreatitis because of deposition of this calcium in the pancreas. Peptic ulcers can happen. Acute kidney injury can happen because of calcium deposition in obstruction and AKI. Lethargy, stupor, coma, and some musculoskeletal weakness. So these are all the symptoms based on the level. So how do you want to evaluate the cause? Yes, anybody? So what is the
So
evaluation? What are the yes?
in this case, a patient, I would like to again repeat the serum calcium level and serum
Very
albumin,
good.
and
Correct. So
also
first of all, confirm the calcium levels again. So okay, very good. So you do repeat the test and confirm whether it is really hypercalcemia. Then and you correct it to albumin levels. Next.
albumin level. Then for the malignancy, I also repeat the PSA level and also bone scanned and
Okay.
one and whole body scan. And also
Okay.
I want to search the other causes like vitamin D level and
Correct.
thyroid hormone level, thyroid related hormone level, serum
Correct.
cortisol, thyroid profile.
Okay,
Um,
good. Yeah, I think you told most of it. So this is what we said. So this is the algorithm for evaluating a case of hypercalcemia. First thing repeat the test and confirm it again. So after doing that, first thing you'll look into is parathormone level. So what is the parathormone level? If it is already high, it is primary hyperthyroidism. If it is normal, then it is primary hyperthyroidism. Mainly in our case in malignancy, we see it is low. So that means that hypercalcemia is not because of parathormone. Then you look into the next hormone which is commonly caused, that is either your calcitriol, vitamin D, or so parathormone related peptide, which is commonly seen in your malignancies. Okay, so next you see there is whether the parathormone related peptide is elevated or not. If it is elevated, so it is humoral cause of hypercalcemia, mainly in malignancy. We all know malignancies, certain malignancies will lead to elevated levels of parathormone related peptide, which acts like parathormone and absorbs more calcium. And there is hypercalcemia. So this case is parathormone related peptide. Next, we'll look into calcitriol. So what is it? So yes, calcitriol is elevated. So it is probably because of lymphoma, granulomatous disease. In those conditions, calcitriol remains elevated. So next is what is your vitamin D levels? So if it is high, that means your patient could be because of vitamin D intoxication most commonly. Next, or you should be looking into so causes like multiple myeloma, where you'll do a protein electrophoresis and free light chain to confirm your diagnosis of multiple myeloma. Okay, so this is how you work it up. So mainly you'll do a few tests like parathormone, parathormone related peptide, vitamin D levels, and things like that. So these are the laboratory parameters. And I told you should evaluate calcium, phosphorus, parathormone, vitamin D, and parathormone related peptide. Our concern in this particular case is because of humoral hypercalcemia, because of the parathormone related peptide which is released by the malignancy. Hypercalcemia can also happen because of osteolytic metastasis. See, in this case also it was there, correct? So there was mets to the bone, and those can uh, cause osteolysis. Usually, prostate doesn't cause osteolytic; it is usually osteoblastic. But if it is any other case, it can cause breakdown of the bone. Osteolysis can happen, and that can also lead to high calcium levels. So this is how you will work it up. And this question was asked corrected calcium. So the formula is zero point 0.8 into 4 minus the serum albumin plus serum calcium. In our case, it is 2.2 was the albumin and serum calcium was 13.3. So zero point 0.8 into 4 is the normal level. So 4 minus 2.2 plus 11, 13.3, which is nothing but 14.74. It is actually a very severe form of hypercalcemia. Now coming to the next question, how do you manage this? How do you manage hypercalcemia or treat hypercalcemia?
Uh, at first, I ensured the good hydration by the IV
Very good.
normal saline, and my urine output target is 100 to 200 ml per hour. And
Correct.
is there is BP stable, and I can use IV fusimide, and then
Correct.
anticalcemic drug bisphosphonate, and also
Correct.
with phosphonate and a fluid, I also add the calcitonin.
Calcitonin. Yeah.
And there is a refractory cases, or in case of, then I go for the hemodialysis.
Correct. If it is refractory case, or if your patient is already very serious, then you don't have time for all these medications to work, then you can go ahead with dialysis. So absolutely, she's already mentioned all of it. So this is the entire flowchart or list of drugs which are available. First thing is hydration. Okay, not diuretics first. First, hydrate adequately, give adequate plenty of fluids. After that, so it will improve the volume, it will dilute the calcium, and also lead to increased urinary excretion of the calcium. Next, you'll give some diuretics. It will forcefully remove not any diuretic, it is a loop diuretics to be given. Okay, don't give a thiazide and expect the calcium to go down. We all know thiazide diuretics will retain calcium and it will worsen your calcium levels. So not a thiazide diuretic, it is a loop diuretic. Usually furosemide is given 20 to 40 mg after adequate hydration. Okay, so before that don't give, because it will worsen your hypotension, because already I told you this patient usually will have polyuria and dehydration. So don't give it before that. So adequately hydrate first, and then you start your loop diuretic. Calcitonin can be given. This is mainly useful in your cases. Can be given. It will improve deposition. So next line of drugs are your bisphosphonates. It can either be zoledronic acid, palmitronate. So zoledronate is what is usually used. The dose is 3 to 4 mg. Okay. Next is your glucocorticoids. This is mainly useful if your calcium is high because of a lymphoma. So it mainly help in reducing the calcium levels there. Other options available are denosumab, or you can try a calcimimetic agent like sinacalcet. And nothing works, it is refractory, and you don't have time, and you should rapidly reduce the calcium levels. Then it is only hemodialysis. Okay, so this was the first one. Next, a 30-year-old came to the hospital with history of trapped in a burning house for about 30 minutes. Did not sustain any contact burns. This was associated with persistent cough and breathing difficulty. So he was trapped inside a house when fire happened. He was there in the house for 30 minutes, after which he was rescued. But there were no contact burns, but he had some persistent cough and breathing. He was pulled out from the building house by the fire personnel. Uh, she was complaining of severe headache and visual disturbance. After that, he was complaining of severe headache and visual disturbances. On examination, found to be febrile. SpO2 was normal, but distress was there. Sinus tachycardia was there, and the BP was normal. So what do you think this is?
Carbon monoxide poisoning.
Okay, so there is burning inside a house. So severe headache and visual disturbances. Cough is there, breathing is there. That means there is some inhalational injury. And company has severe headache and visual disturbance. We should see what is the reason for that. Is febrile also, but the SpO2 says normal and hemodynamically stable. Yes. So when you suspect inhalation burn injury, so inhalation injury suspected whenever you have a burn in a closed space, okay, and there is history of loss of consciousness, there's obvious stridor or wheeze, some respiratory involvement is there, hoarseness of voice is there, or when the person coughs and he gets an expectoration which looks carbonaceous, there is some soot particles in the sputum, or if the burns are involving the face, oral cavity, or nasal mucosa, or you see there is evidence of singeing, that is burning of the facial hair is burnt, or nostril hair is burnt, or when the patient gives history of inhalation, he himself tells that I inhaled uh, hot fumes. So these are all the cases where you'll suspect a inhalational burn. Okay, because contact burn everybody knows, you can obviously see it, it is there, but these inhalation burns you don't see it externally, but that doesn't mean that there are no burns, because this can become very very bad if you don't recognize them very early. Okay, when do you suspect? These are all the cases when you suspect a inhalational burn. So what are the indications for endotracheal intubation in burns patient? Anybody? Your usual indications will always be there. So whenever the GCS is low, whenever there is respiratory distress, so all those indications are there. Other than that, anything else is there. So these are the list of indications. Nothing different in your patient with the burn, except for a few. So as I told you, shortness of breath is there, wheezing is there, rales are there, ronchi is there, stridor is there, hypoxia is already there. The patient is very, very agitated. There's altered level of consciousness. This is GCS less than 8, like any other place. Voice changes are there. That means that there is some inhalational injury, so you should consider intubation. Total body surface area burns is more than 40%, or severe facial burns are there. You should consider intubating him early. Carbonaceous sputum, as I told you, if you're suspecting inhalational injury, and if it's mild form, you can wait. But if there's already some voice change, some airway edema is expected, that is going to become very bad later. So it is better you intubate this particular patient. So last two is for inhalational injury. So these are all the patients who needs to be intubated. So name a grading scale. Anybody could name this? So the name of the scale is something called as abbreviated injury scale. So what does it do? Is it estimates survival. It tells about mortality benefit. When it tells about the mortality rate. So anybody with the lower grades, I'll show you the score. So this is the score. So abbreviated injury scale. This is mainly for inhalational burns. Okay, so grade 0 to grade 4. Grade 0 means no injury. So there's no carbonaceous deposit, no erythema, nothing is there. Edema is not there. Bronchoria, that is increased secretions are not there. No airway obstruction is there. So any of things is there, it's grade 0. Grade 1, mild injury. There is minor or patchy areas of erythema, that is redness. Carbonaceous deposits are seen in the proximal or distal airway. This is actually finding on bronchoscopy. Okay, so you do a bronchoscopy and you see there is some erythema inside, or there is carbonaceous deposition in the airway. So that is when you say this. In the distal bronchi or any combination. Grade 2, it is moderate injury. Grade 3 is severe injury, and grade 4 is massive injury where there is evidence of mucosal sloughing, necrosis. Already there is endoluminal occlusion. All of this is happening. Then it is a abbreviated injury scale. So what is the importance of it? It tells you about the mortality rate. So anybody with early grades, that is very minor injuries, the survival rate is around 84%. If it goes beyond, if the injury is very, very severe, and there is a severe inhalation injury, the survival rate is around 50%, around 57%. That means the death rate is around 43%. Okay, so this is a scale. So if you have a patient with inhalational injury, you can apply this score. I mean, you can look into this scale and you can prognosticate the family about the risk of mortality. Abbreviated injury scale. This is done during bronchoscopy. So after airway injury, you either intubate the patient or assess the airway using a bronchoscope, and this is how you'll grade them and you will prognosticate them. So how do you confirm carbon monoxide poisoning? So when do you suspect, first of all, when do you suspect carbon monoxide poisoning?
In case
Yes,
of there is a history of the closed door,
correct.
and
Inflow space
yeah,
burns, inflow space fires. So
yes.
that is when you'll suspect carbon monoxide. So how can we confirm?
So,
So carbon monoxide can be confirmed through blood gas co-oximetry. All of you know that. So you can't do a regular ABG and do it. You should do a co-oximetry where you get oxyhemoglobin and carboxyhemoglobin. Only then you'll come to know there is carbon monoxide poisoning. So what is the effect of carbon monoxide on the ODC, oxygen dissociation curve? Anybody?
Shift to left.
Yeah, there is shift to left. That means,
higher affinity for the
yeah, higher
oxygen.
affinity. So there is no release to the tissues. So your tissues can have hypoxemia. Okay. So what is the next common poisoning which can happen in closed door burns?
Cyanide poisoning also the cause.
Yeah, the other common thing which can happen is cyanide poisoning. So what is the antidote for cyanide poisoning? You give oxygen after that.
With hydroxycobalamin,
Yeah,
sorry,
hydroxycobalamin, sodium
and
thiosulfate.
sodium thiocyanate.
Yeah, so these two other things. So here, so what is the treatment for carbon monoxide poisoning? You suspected.
and high 100% oxygen.
Yeah, 100% oxygen first. If the levels are very, very high, then you have a facility, you can consider hyperbaric oxygen.
Hyperbaric oxygen.
Correct. Okay, coming to our third case, a 63-year-old male patient, a known case of diabetes, hypertension, and acute lymphoblastic leukemia, received a cycle of chemotherapy, following which he developed fever with running nose, some breathing difficulty, hypoxemia, some hemodynamic instability with severe tachycardia and hypotension. So when you asked the wife, she told the history. From the history, they gave a drug called Zika Tevgene Silolucil. My God, very difficult drug. On an examination, it was febrile. 101 was the temperature. Heart rate was 110. BP was 104. And a small dose of Norad. SPO was 93% on face mask and 5 liters per minute. Anybody has idea what this drug is? I think you would have Googled after the test maybe. But before that, it's a new chemotherapy drug which is being used. Anybody?
No idea.
No idea.
Okay, nobody Googled also. You forgot the drug. Could not remember the drug. Okay, yes.
No.
Okay, this is a new class. I told you chemotherapeutic drug. The class is chimeric CAR T cell therapy. Okay, you would have all heard about it. They are asking questions about this. So usually you miss reading it. So that's why I added into it. So this is all you need to know about this therapy. This is a new therapy. What is this? It's a chimeric antigen receptor T cell immune therapy. So what are we using? So actually, what are we doing in this therapy? I'll just brief it. So after the class, whenever you find time, you can get an article and read about it. They are asking about this. They are all, exhausted asking about the old drugs. So there have been few questions which have been asked about this. So here, what are they trying to do is they're changing the T cell, they're altering the T cells and giving it to the patient, and those will go and fight the uh, uh, they'll go and fight the tumor cells. Okay, so that is what they are doing. So they are, by altering the T cell function, they're making them fight against the tumor cells, and they're destroying, that will destroy the tumor. And this is a new class of chemotherapeutic drug. So what are they doing? So that's what is there. Patients' T cells from peripheral blood are engineered ex vivo. So they're taken and repaired. They're modified outside with a recombinant T cell receptor or a chimeric antigen receptor, which mediates antibodies. So what this is, when you give it back, so it will go and produce antibodies that will go and destroy the tumor. Okay, so that's what it does. So other drugs in this group are these drugs, little complicated names. These are all the drugs which are available in this particular class. So you may be asked about CAR T cell therapy. Okay, so that's why I've added this slide. What is this clinical condition? This clinical condition is called cytokine release syndrome. So what happens is one of the complication of the drug, which is seen when this therapy is given. So they release cytokines. So when they, like how we, so there is release of cytokines, because I told you there is modification, you're altering the immune system, you're altering the T cells in this particular therapy. So when you give this, so it will cause significant release of cytokines. And when cytokines is released, like how we see it in sepsis and all, same things are seen here also. Okay, this is called as cytokine release syndrome. This complication is called as cytokine release syndrome. So how do you manage this? Again, so usually there is some role of, because we are hampering the immune system, so you need to give some broad spectrum antibiotics. So preemptive broad spectrum antibiotics are given. Some symptomatic measures like antipyretics. There is fever, you give antipyretics. There's hypotension, because as we saw, so fluid resuscitation. And I told you there is increased release of cytokines in this particular condition, and we all know the very popular and easily measurable cytokine is your interleukin 6. We've all measured it during our COVID times also. So this is one of the commonest cytokine. It is one of them. Okay, there are other cytokines which are released also, but interleukin 6 is what they have measured, and they have found that it is significantly elevated. So you can use a drug which will block or just block this interleukin 6, and the commonly used drug is your tocilizumab, which we have used during COVID times. Correct? You remember? So tocilizumab is the treatment for this particular condition. I told you there is elevated cytokine levels in the body, which is causing the symptoms. You need to control the cytokines. One of the cytokines is interleukin 6, and you give an interleukin antagonist. That is your tocilizumab. The dose is 8 mg per kg. If it doesn't subside with that, the next drug is your steroids. You can give dexamethasone 10 mg IV 6th hourly. So this is the drug of choice. Okay. What other complications? I've listed all the complications, so don't worry. That's what I said. If you can read. Otherwise, if you can just revise this, just remember them. So any new drug, chemotherapy, they've asked. So this is the thing. What are other complications which happen? Tumor lysis syndrome, like any other chemotherapy drug, you can have tumor lysis syndrome. What are the characteristics of tumor lysis syndrome? Anybody?
Hypercalcemia, hyperkalemia,
Yes, next.
uricemia,
Hyperuricemia, next. Hyperphosphatemia, hyperkalemia.
hyperphosphatemia.
Okay, all of this. Okay, next, other things which can happen with any other chemotherapy drug, infections and sepsis. Our present condition, that is cytokine release syndrome, is something called as immune effector cell associated neurotoxicity syndrome. Again, there will be some neuro symptoms. I'll show you what those symptoms are. Like similar to your HLH, that is hemophagocytic lymphohistiocytosis, similar picture can also be seen following this therapy. So you get a case post CAR cell therapy, you develop some hemophagocytosis, bicytopenia, organomegaly. If they tell something like that, you should tell it is a case of immune effector cell associated hemophagocytic syndrome or post CAR cell therapy HLH. Okay, it can also cause cardiovascular toxicity or renal toxicity. So medium term complications include delayed tumor lysis syndrome or delayed cytokine release syndrome or delayed immune effector cells associated neurotoxicity, B cell aplasias and hypogammaglobulinemia, delayed and prolonged cytopenias and infections. Don't get frightened when you get this question. You may or may not be asked, but I want you to know if at all they ask you, you should not panic in the exam. So that's why I've added this slide. So this is a complete list of complications which happens, and it has been graded also. So I think I'll not go into the details of all of this. So I'll just tell you the first part. So this is your cytokine release syndrome, which I've already discussed. It again is divided into grade 1, grade 2, grade 3, grade 4. Grade 4 is the worst form, grade 1 is the mild form. And you can see everywhere, I mean, it will be initially supportive care, tocilizumab, dexamethasone, and things like that. Okay. And this, you can read it a little later. So next question. So a 38-year-old male patient was admitted to the ICU with history of high voltage electric injury to his right upper extremity. Mainly for observation, they said he looks stable, no need to worry, let him get admitted. So he was in the ICU. On day 2 of admission, the patient developed dark brown colored urine, and gradually there was reduced urine output. Initially it was dark brown, after some time you saw that the urine output also reduced. His creatinine was 2.2, urine dipstick test was positive for heme pigment, and CPK done was 20,000 international units per liter. So what do you think is this case?
Case of
Rhabdomyolysis.
rhabdomyolysis.
Yeah, rhabdomyolysis, and that is leading to AKA also in this particular patient. What was the heme pigment that was positive?
Myoglobin.
Correct, myoglobin. And why is CPK elevated?
Because muscle breakdown, skeletal muscle breakdown.
Yeah, so high electric current, so muscle breakdown, and that is caused CPK to be elevated. So what about probable cause? I mean, very obvious, it is myoglobinuria. So what are other causes which can, I mean, other conditions can lead to dark colored urine? It can be hemoglobinuria, sometimes even concentrated urine. Your patient is severely dehydrated, so that can also be there for dark colored urine. If any, so these are the differentials for dark colored urine. So in this case, it is definitely myoglobinuria. So what is the probable cause of AKI in this patient? Rhabdomyolysis and myoglobinuria. I think you all know the pathophysiology of myoglobinuria, correct? So it goes and gets deposited, sometimes causes radical damage to the tubular cells and all. So that is how your patient develops rhabdomyolysis. So how do you manage this patient? Prevent further breakdown. Anyways, always try to prevent further muscle breakdown. Aggressive fluid resuscitation. If the patient becomes anuric or oliguric AKI, then consider renal replacement therapy. I mean, if your center is practicing, can even talk about forced alkaline diuresis also, but there is no recommendation, no strong recommendation for this, but hydration definitely yes. So you can just comment hydration and renal replacement therapy if your kidney is not functioning. So next case, a 63-year-old male patient recently diagnosed with acute myeloid leukemia came with history of breathing difficulties since last 4 days, which worsened since this morning. This was associated with bilateral lower limb digital ischemia and altered level of consciousness. So in the bilateral lower limb, there was some digital ischemia and he had some altered level of consciousness. So on findings, SpO2 was 84%, total counts were 1 lakh per cubic millimeter, lactate was 6 milligram per deciliter, potassium was 6.9, but there were no signs of hyperkalemia on the ECG. Yes. So anybody wants to say what is could be?
Hyperviscosity syndrome.
Correct. Hyperviscosity syndrome, hyperleukocytosis is there. So why is there lactate elevated?
Uh, cytosis.
Viscosity causes peripheral perfusion hamper or
Correct. So there is
thrombosis.
peripheral ischemia happening. Correct. There is impaired perfusion, so also lactate. So they say potassium is 6.9. but no hyperkalemic signs on the ECG. Why do you think this is? Yes, anybody? 6.9 should have produced at least a few ECG changes, correct? Something should have been there, but nothing is there. So, what do you think is the reason?
Pseudo.
Maybe
Yes, yes. I said yes. It is pseudo hyperkalemia. How did that pseudo happen?
during the trauma
Right. So you
response.
drawed it, and you know these are all tumor cells, correct? So when it is in the sample, the tumor cells have lysed, and that is released potassium. So that is why in the serum you're getting 6.9, but on the ECG no, because in the body the potassium level is normal. Okay, this is pseudo hyperkalemia. So what is the probable diagnosis? Hyperleukocytosis and leukostasis. There is stasis happening. That is why you have digital ischemia because of the vascular occlusion. There is lactic acidosis and there is pseudo hyperkalemia as well. Okay. So how do you manage? Again, you should reduce the viscosity. Why is this a problem? This problem is happening because there is decreased viscosity. The blood is increased viscosity. It is very, very viscous, sluggish flow, absent flow, occlusion of the microcirculation. So what you should do? First you should do is reduction of the viscosity. How can the easiest way to do is your fluid resuscitation. You can do cytoreduction therapy. So you should reduce the cells. How can you do? Either you can do a induction chemotherapy, give a hydroxyurea or leukophoresis. What is leukophoresis?
Like plasma.
Plasmapheresis, sir. Like
Yeah, similar to that. So plasma, if you're removing, it's called plasmapheresis. Here we are removing WBCs, correct? Because it is leukostasis. So we are removing leuka, so that is why it is leukophoresis. So this is the easiest and fastest way to do it. If it is very mild form, you still have some time. You can try with chemotherapy or hydroxyurea and leukophoresis if it is SOS emergency. Okay, now next case. A 69-year-old male, weight is 45 kgs, a known case of carcinoma esophagus, diagnosed a year back, and he had received post chemotherapy, came with complaints of reduced food intake and loss of significant weight since last 4 months. He was advised endoscopy and debulking of the tumor to reduce his dysphagia and facilitate his feeding, but was not willing as it was associated with high risk of peri-procedural complications. His labs were done, which showed hemoglobin 8.2, total counts of 17,000, platelets were 1.2 lakhs, creat was zero point 0.7, GRBS was 84, sodium 129, potassium 3.7, phosphorus 1.2, magnesium 1.6, calcium 8.1. So, because of his difficulty, you saw him, he looked very cachectic. You inserted an NG tube, started enteral feeds, and the target was to reach 1,500 kilocalories per day and 70 grams of protein per day. On day 3 of ICU stay, he developed type 2 respiratory failure, following which he developed toxidopontis and had a cardiac arrest. Okay. So, what is the reason for his worsening clinical condition? What do you think is this case? What are the major abnormalities you see here?
Refeeding syndrome.
syndrome.
So this is CBS, so we don't have much discussion. But for maybe if you get this case in the CCS, you'll have some discussion happening. So why do you think it is case of? Yes, your answer is absolutely right. It is refeeding syndrome. So first of all, what are the risk factors in this patient? So you can see it's a elderly, very cachectic person, and he has not been eating since long time. And in his investigations, I think all are low. Hemoglobin is low, platelets are low, and more important for us with respect to refeeding syndrome, his electrolytes are all low. Phosphorus is low, magnesium is low. Yeah, and other what is the other problem which happened in this case? Okay, all are already low. Fine.
Phosphate dependent hypomagnesemia.
Yeah, correct. So hypophosphatemia, hypomagnesemia is already there. So I mean, why did this patient have refeeding syndrome? You
Because
started
the
your
patient
feeds
was
for correcting this electrolytemia,
yes,
and your targets were
yes,
also very high. Correct.
Right.
So you give a very high target. So if your patient is already having high risk of developing refeeding syndrome, you should have corrected these electrolytes, started your feeds at a slower rate. So you see, if this patient 1,500 kilocalories is very, very significant. Correct. And even proteins both were very high. So you thought you will improve his nutrition, and you gave him very high nutrition, and your patient's body shifted to anabolic stage, and all the electrolytes which are already low were again became very low because now the body is utilizing them for anabolism, and this way whatever was there worsened further. Should have ideally, what should have you done? You should have corrected these electrolytemias first and started his nutrition slowly and reached the target very, very slowly. Correct. That should have been ideally done. So why do you think your patient is having type 2 respiratory failure?
due to the high carbohydrate burn, but it is carbon dioxide production is very high.
Okay.
No.
Apart from that, it will also
Hypo.
lead to decreased ATP production because your phosphorus is low, and that will lead to muscle weakness. So carbon dioxide production is more, and your muscles are very weak to push out that carbon dioxide. That is why your patient develop type 2 respiratory failure. And again, this dysrhythmia and cardiac arrest, all is because of dyselectrolytemia, which is there. Clear? Either it could be potassium, phosphorus, all of these can lead to dyselectrolytemias and arrest. Clear? Same thing. So what is the provisional? All of you have told it right. So refeeding syndrome, how do you define it? So a series of metabolic disturbances related to the transition from a, that's what I told you. There was already a prolonged catabolic state. The patient was not having nutrition, correct? So he was not taking intake because of CA esophagus. So his nutrition was very less. So it was in a catabolic state. So whatever was there in the body's proteins were all being utilized for glucose production. So whatever was stored in the body was being utilized. Suddenly you gave him a full-fledged meal. So now it shifted from catabolic to anabolic. So it will lead to reduction in various parameters. So that is what is the reason for your refeeding syndrome. So what happens? There's significant fluid and electrolyte shifts. And this leads to severe hypophosphatemia, hypokalemia, hypomagnesemia, thiamine deficiency, severe peripheral edema, and severe manifestations like neuromuscular dysfunction. This patient had type 2 because of that, cardiac failure, and even respiratory insufficiency. All of this will happen in your case of refeeding syndrome. So, okay, during prolonged fasting, that's what I told you, the body adjusts itself. So, the same explanation is there here also. So, when you start anabolism, so I told you, so for ATP production or cell buildup, you require ATP. So, whatever is available, it will all, whatever electrolytes were there, it will start. So, if your patient had normal electrolyte levels, if it gets utilized in anabolism, you wouldn't have had refeeding syndrome. But his electrolytes were already low, and you have not replaced it, and now it is getting utilized in the body also. So that will lead to worsening of your dyselectrolytemia. So these are the features. Hypophosphatemia will lead to muscle weakness, tetany, paresthesias, rhabdomyolysis can also happen in this case. So delirium, seizures, acute respiratory failure, heart failure, arrhythmias, hypoxia, hypotension, shock. Because every organ in the body requires phosphorus to, every to function properly. So there is low phosphorus, all of these problems. Again, you can have hypokalemia, hypomagnesemia, thiamine deficiency, and you can have even fluid overload as well. So what precipitated, as I told you, aggressive nutrition initiation in a severely depleted case. So how do you calculate, how do you estimate nutrition deficiency or at risk of nutrition or at risk of malnutrition? How do you assess it?
NRI score must.
Yeah, NRS 2002 score, Nutrix score, whatever score you have. So one of them will assess. So in this case also you'll assess. If it is very high, you started very slow, correct? So no replacement. So what are the, why it got precipitated? One, it is aggressive nutrition. And next, there were no replacement or correction of dyselectrolytemia. You did not correct them. And you did not monitor them also, correct? So these three are recommended to prevent. So whenever you're starting nutrition in a severely malnourished, you start it slow and you monitor the electrolytes, correct the electrolytes if they are already low. Or you can start simultaneously. You can start nutrition and the electrolyte correction simultaneously. Okay. So how could I have prevented? So I told you, so assess the risk. I told you like one of the scores you can use and assess the risk of refeeding. This patient is high risk of refeeding means you correct the electrolytes, start slow feeding. Okay. So restricted feeding for 48 hours, correction of dyselectrolytemia, mainly phosphorus and potassium, frequent serum level check and adequate replacement. So keep checking and replacement. So what happens during refeeding syndrome? So this is as per the ESPEN definition. So during refeeding syndrome, there's decrease in the serum phosphorus levels to less than 0.65 millimoles per liter, or there was a better phosphorus level, but it dropped after you started a feeding to by more than 0.16 millimoles per liter. That is called as refeeding syndrome as per ESPEN guidelines. Okay. So electrolyte should be measured at least 2 to 3 times a day, and if supplemented if needed. So these are all recommendations from the ESPEN guidelines for preventing refeeding syndrome. So for your reference, so normal phosphorus level is typically between 2.5 and 4.5 milligram per deciliter. If you give it in moles, it is 0.81 to 1.45 millimoles per liter, or roughly 1 milligrams is nothing but 0.32 millimoles. Okay, you multiply it by 0.3. Okay, next case. A 78-year-old male patient, a known case of CA lung, post lung resection and chemotherapy done 2 years back, and was lost to follow-up, came to the ER with complaints of swelling and redness of the face and upper chest. So this was associated with some stridor and altered level of consciousness. On examination, there was presence of dilated engorged veins on the chest wall. chest X-ray showed the presence of some dilated upper mediastinum or superior mediastinum. So what do you think is the cause or condition here?
Superior vena cava obstruction.
What?
Superior vena cava obstruction.
Correct. Vena cava obstruction, known case of CL lung, lost to follow-up, now stridor, decreased level of consciousness, so swelling and redness of the face. Why there is swelling and redness of the face in upper chest?
There is a venous obstruction by the
By the
tumor.
recurrence
By
of
the
the tumor,
tumor.
probably. Yeah, superior vena
Probably
cava is getting compressed, and because of which the area which drains into superior vena cava, that is your upper limb and the upper part of the chest and face, is impaired. And because of this, what will happen? Why is having altered level of consciousness?
there is a decreased venous return from the
Correct. So
brain.
even the cerebral venous return is
Altitude.
less. Significant cerebral
Yeah.
edema maybe. That's why there is altered level of consciousness. Why stridor?
Stridor, it is due to the compression of the larynx or trachea.
Either it can be
Mediastinum.
local compression by the mass itself, or
Uh-huh.
due to impaired venous return, the edema of the airway is also a possibility. Okay, correct. So what is this? Either can be recurrence of lung mass compressing on the superior vena cava, resulting in superior vena cava syndrome. So how do you confirm it? So you need to do a CCT of the is the imaging modality of choice to determine the cause and degree of SVC obstruction, as well as to see if there is any thrombus. So either that's what I told you. Either it can be external compression on the SVC, or these are prothrombotic conditions which can result in thrombus formation inside the SVC and lead to obstruction.
So
So what are the
what is the gold standards of CTV V or MRV?
CT angiogram will, I mean, sorry, CT venogram will tell you CT is enough. I mean, MRV may not be available everywhere. So CT venogram is adequate.
Okay.
So signs of cerebral edema. So what are life-threatening conditions that can be happen in this patient? That's what cerebral edema is there. It can be very severe. It can lead to herniation, coma, things like that. Other life-threatening is severe laryngeal edema. Again, it can be because of internal edema, because of swelling, or external compression and causing airway collapse, or hemodynamic compromise. Correct. There is impaired venous return. So it is similar to your obstructive shock. So these are the three severe life-threatening conditions that can happen in your SVC syndrome. So how do you manage these conditions? So each one you can pick up. So I told you raised ACP, cerebral edema, impending herniation, start anti-edema measures, and you try to open up this obstruction as early as possible. If it is a thrombus, give some thrombolytic agents, anticoagulation and all, or try thrombectomy. If it's external compression, you can consider debulking and things like that. So airway edema or compression. So that's what which can make, obviously it is upper airway obstruction, correct? So it can make your endotracheal intubation also difficult. So we can anticipate a difficult airway, plan awake fiber optic or flexometallic tube or surgical airway technique may be required to prevent airway obstruction and cause life-threatening condition. So need to maintain spontaneous respiration. We all know if you paralyze this patient, so you'll be losing the airway. So always try to keep him spontaneous as much as possible. Another important thing is IV access, preferably on the lower extremity. Correct. If you put it in the upper extremity, because there's obstruction, whatever drugs you give, it will not reach the circulation. Okay. So in this case, you should put it in the lower extremity. It is exactly opposite to your pregnant patient. In pregnant patient, I want it above the diaphragm. In this patient, I want to keep it below the diaphragm. Right? Okay, next case. A 39-year-old with lymphoma received chemotherapy 5 days back, and now he came with some history of nausea, vomiting, anorexia, fatigue, and muscle cramps. So, what are the investigations? You did his investigation. You saw his sodium was 134, potassium was 6.3, chloride was 96, phosphorus was 8, ionized calcium was zero point 0.7, uric acid was 9, and creatinine was 1.9. So, what do you think is the condition?
Tumor lysis syndrome.
Absolutely. So this is a case of lymphoma. We all know lymphoma is high risk for tumor lysis post chemotherapy, and you see there is dyselectrolytemia and factors which will support your diagnosis. So what are there in this? You see there is hyperkalemia, hyperphosphatemia, hyperuricemia, hypocalcemia, and acute kidney injury. Yes, your diagnosis is right. It is tumor lysis syndrome. How do you prevent and manage this complication?
So maintain the good hydration. Your output maintain 100 to 200 ml per hour.
Okay.
Monitor the ECG
Hydration,
and monitor the ECG, cardiac
monitor
monitoring,
the
and prevent the hyperkalemia
correct.
and rasburic acid used for the
Uric acid,
hyperuricemia, and in
correct.
refractory cases to go for hemodialysis.
Okay, that's the first important thing is you should always worry about potassium first because you can have a cardiac arrest situation and all. So first you can address potassium and as you said, hydration and other electrolytes and uric acid. Correct. So this is how you. These are the British Society Hematology of guidelines. So major recommendations. How do you prevent it? So all patients at risk should receive adequate IV hydration. Urinary alkalization, as I said, is not recommended now. Intermediate risk patients can be given allopurinol for up to 7 days so that uric acid levels are not high. High risk patients, so intermediate allopurinol. How does allopurinol work? Yes, anybody? What class drug it is? How does it work?
Xanthine
Allopurinol acts xanthine
Yeah, xanthine
inhibitor,
oxidase inhibitor. Correct. It
inhibitor.
prevents. Correct. So you all know it. So you should know it. So allopurinol. So or respiricase. Okay, in high risk patients, because you don't have so much time, you give respiricase. Can we give both of them? Allopurinol and respiricase.
No.
Why? So
Uh,
both act at a different level. Correct. Allopurinol acts at the proximal stage, and respiricase acts below. So if you give
oh,
allopurinol, that itself you don't need
reduce
for
the
giving respiricase. Correct. Your respiricase will convert uric acid into a allantoin, which is more soluble
allantoin.
and gets excreted in the urine. But your allopurinol will prevent uh, uric acid formation. So in high risk cases, you give respiricase first because you want to convert whatever existing uric acid is there. You want to wash it out from the system. Okay. There may be no role for allopurinol there because which will prevent formation. A patient receiving respiricase should not be prescribed allopurinol, as I said. So how do you treat it? So this is about prevention. So treatment. So respiricase 0.2 mg per kg per day should be given with duration depending on the clinical response. Dialysis indications include refractory. As I said, you tried everything refractory, so you go with dialysis. Target urine output of at least 100 ml with crystalloids and asymptomatic hypocalcemia should not be treated. Don't treat give calcium, okay? Because already there's high phosphorus. You give calcium, that will get precipitated. It will cause complications, and you can add phosphate binders if you are not dialyzing the patient. So next case, 54-year-old female patient, a known case of diabetes, hypertension, came with history of headache and fever on and off since 3 days. Now came with altered sensorium. Okay, so basic investigation done for anemia. So because somebody told there is anemia, so they did some workup, showed the following. So what did they see? There was pallor, hemoglobin was 8.1, total counts were 5,400, platelets were 77,000, creatinine was 3.2 milligram per deciliter. The baseline was said to be 1.1. Otherwise, electrolytes were normal, sugars were normal. Peripheral smear, which was done for the anemia workup, showed microcytic hypochromic anemia with some thrombocytopenia, and there was some more than 15% of fragmented RBCs. So LDH was also done, which showed 1,800 international units. Haptoglobin was done, which is less than 5 milligram per deciliter. So what do you think is this case?
TTP.
TTP, how?
TTP. Because
Yeah,
Uh,
patient
how?
had altered conscious level,
Okay,
MAHA, and
okay,
thrombocytopenia,
okay. Next.
and
AKI,
renal,
renal.
renal uh, rise
Fever
creatinine.
also, right? Pentad, you missed one. Fever.
Pen-
Fever already told at first.
Cold. Okay, sorry, I missed it then. Okay, yeah. So fever, altered sensorium, MAHA, thrombocytopenia, and some altered liver function. I mean, sorry, renal function as well. Okay. What is the importance of this LDH?
LDS it indicate that it is a pre cell
There
breakdown
is
or
hemolysis. Correct. There is cell
hemolysis.
breakdown. Yeah. So what is the importance of haptoglobin?
Haptoglobin is reduced in case of hemolytic anemia. Uh,
Uh, any anemia, it will be, I mean, mainly when there is hemolysis, correct. So whenever there is high hemoglobin, so that will bind to your haptoglobin and it will get removed from the body. So that is the reason why your haptoglobin is less. So what is this fragmented RBCs?
it is the
Histio-
hemolysis sites.
Histiocytes, correct. So why is it happen? So these
It is a
patients with
breakdown.
TTP will have thrombosis, and when the RBC are passing through it, it will get lysed. Okay, that is why you have more than 50%. It is very significant finding. Okay, schistocytes. Other name for fragmented RBCs here, schistocytes. Okay. So what is the probable diagnosis? You are all right. There is fever, headache, altered sensorium, anemia with fragment RBC, nothing but your MAHA. So thrombocytopenia, altered renal function. So all of them fit into your pentad of TTP. Okay. Next, how do you confirm? It's actually clinical only. Okay, no need to do any test to confirm it. But you still want to do it, you can do this. So it's a clinical suspicion. So you have this all pentad. So it is a clinical diagnosis. if you want to do some lab findings, you can do ADAMS 13 levels. So what is this ADAMS 13?
Cleave the von Willebrand factor.
Yeah, so this is a enzyme which cleaves your von Willebrand factor multimers. A big molecule of von Willebrand factor is broken down by this enzyme, which will make it to small particles. So here there is reduction in the activity of ADAMS 13 level. So what happens because of this? The von Willebrand factors are big molecules; they're still circulating the body, and that will attract more of platelets, and they'll cause thrombus, and because of which you'll see all these complications. Either you can do ADAMS 13 activity, which is less than 10%, or you can do ADAMS 13 antibody levels. Okay, both can be done. Okay, usually ADAMS 13 is done. But again, I'm telling you, if they ask you how do you confirm, it is a clinical diagnosis. Okay, no need to do ADAMS 13. Any specific test they ask for you, then you can tell ADAMS 13 activity you can do and ADAMS 13 antibody levels you can check. How do you manage? Urgent
Plus
TP, therapeutic plasma exchange, class 1 indication. So few cases, if it doesn't respond, you can try corticosteroid therapy. Other therapies have also been tried like B-cell targeted immunotherapy, rituximab, and now a new specific drug which works on von Willebrand factor called caplacizumab is there. So you should know about this drug also. Therapeutic plasma exchange, corticosteroid, rituximab, all of you know. Other two therapies are B-cell targeted immunotherapy and caplacizumab. Okay, so this will specifically inhibit your von Willebrand factor multimers. Okay. So next, what is the evidence for extracorporeal therapy? I told you category 1, grade 1A recommendation for therapeutic plasma exchange. What is the mortality benefit? So mortality was more than 90% without plasma exchange. It has been reduced to 5 to 10% following your plasma exchange. How does it work? It removes anti-ADAMS 13 antibodies which are there. Apart from that, we are doing therapeutic plasma exchange. Correct? We are not doing plasmapheresis. So we are replacing it with FFP. So that will replace your ADAMS 13 activity. Right? So you're removing the antibodies and you're replacing ADAMS 13 activity. So, and how do you write a prescription for the same? When you're writing a prescription, you should first mention about the access. So what is the access? Next to the plasma volume, how much is to be exchanged? Usually we exchange around 1 to 1.5 of the estimated plasma volume. Frequency, usually do it daily. What is the replacement fluid? I want to replace the ADAMS 13 activity also. So I will give FFP. So what is the duration? You will continue to do this therapeutic plasma exchange till the platelet counts become more than 1.5 lakhs or LDH is near normal for 2 to 3 days. That means there is no ongoing platelet deposition or no ongoing hemolysis. So that is when you'll stop doing your therapeutic plasma exchange. Okay. So next, so this is the gist in picture. So this is all the various places where it acts. So plasma exchange, it will remove ADAMS 13 antibody and it will replace ADAMS 13 ADAMS 13 so that it will go and break these multimers. And once it is broken, there will be no more thrombosis. No more thrombosis means no more hemolysis and your condition will be better. So why there is AK or kidney injury, kidney involvement in TTP, though it is not very significant as seen in HUS. So here also there is because of diffuse thrombosis. Okay, thrombosis happens even in your renal blood vessels, and that will lead to worsening kidney function. So next case, a 20-year-old primigravida presents at 37 weeks of gestation with anorexia, nausea, vomiting, malaise, fatigue, headache, and abdominal pain for last 5 days. On physical examination, the patient is found to be febrile and jaundiced. On ultrasound you did shows some amount of ascites and IUGR. What is there in the blood picture? Hemoglobin is 11. Platelets are 1.52 lakhs. INR is 2.8. They're given the normal range also. Bilirubin is elevated, 5.1. Creatinine is 2.5. Albumin is 36. Globulin, GGT is 145. ALP 585. LDH, so elevated. All of these are transaminitis is there. Blood sugar is 52 and ammonia is slightly elevated. So what is your diagnosis?
acute fatty liver of pregnancy.
Very good. So acute fatty liver of pregnancy. How did you say that?
There is a sign of coagulopathy, liver enzyme is increased, hypoglycemia, and
Correct.
ammonia
So hypoglycemia
encephalopathy
is very
sign of
characteristic. Okay, so hypoglycemia is very characteristic, and you have transaminitis also. There can be a few other conditions like even hyperemesis gravidarum, all of which are simple hepatitis can also present with transaminitis. But hepatitis will have very significant transaminitis. You don't have this classical picture. You'll have other findings as well.
Smile security.
So this is, yeah, absolutely right. So before the question itself, somebody told it's fancy criteria. So this is acute fatty liver of pregnancy leading to hepatic failure. So what is the only treatment? Urgent delivery and hepatic support. So till you deliver the baby, you have to do hepatic support. So
Sir,
what is the
can you repeat
important?
what is the scoring system? Name of the
I'll come
scoring?
to that. It is there. Next question. Next question. I'll come to that. Okay. So before that, okay. So what is the importance? I told you hypoglycemia is very characteristic. Okay, and it's associated with poor prognosis. If they ask you what is the importance of hypoglycemia, one, it'll help you to make the diagnosis of acute fatty liver of pregnancy. If hypoglycemia is there in your patient with acute fatty liver pregnancy, it is associated with poor prognosis. It is also a prognostic indicator. So this is what I was talking about. What is your scoring system? It's called as Swansea criteria. It is mainly to make a diagnosis. So if there are six or more, in the absence of other etiologies, I told you always rule out other etiologies, then it is suggestive of acute fatty liver of pregnancy. What are the factors are there? You can see here. There's some abdominal pain, polydipsia, polyuria, vomiting, encephalopathy, ammonia levels, AST, ALT, bilirubin, creatinine, glucose, urate. So all of these. Okay. So this is called Swansea criteria. It is mainly to make a diagnosis of AFLP. I think our patient will have many of these. Okay. So next question. A middle-aged male patient was brought to the ER who was found unresponsive at a seashore. This is the ECG of this patient. So what are you seeing in this ECG?
Hypothermia, one waves.
Yeah,
Osborne point,
Osborne
long
waves. Correct.
prolonged Brady and prolonged QT.
Brad is little difficult because we don't have those grids
Yes,
here.
there is.
But there is some pause there, some J point elevation is definitely there, and there's patient from seashore, so we're expecting some hypothermia related changes. Correct. So what I'm seeing, Osborne waves, some bradycardia. We should ideally have the grids, but looks like there's bradycardia and prolonged QT syndrome. So this is the Osborne wave. So we have already discussed this in our hypothermia. So what is likely etiology here? Hypothermia. How do you manage a patient post-drowning? We have already discussed this, so I'll not go into this again. Okay. So next, a 33-year-old female patient, 6 years of married life, conceived post IVF. So was referred post cesarean delivery for breathing difficulty and disease. So after the delivery, they have referred this case for some breathing difficulty and desaturation. There's a history of severe bleeding post cesarean section due to atonic PPH requiring 2 PRBC transfusion. No previous comorbidities other than mildly elevated BP during third trimester, better controlled post antihypertensive. So there's nothing significant comorbidities. Only thing is, during a last trimester, there was some high blood pressure, which became better with some oral antihypertensive medications. So echo done during antenatal checks was normal. EF was 63%. Echo done before referral, that is after the delivery, they did an echo to see why this patient had breathing difficulty. They found that there is some global hypokinesia with poor LV function with EF of 25% and dilated chambers. So what do you think is the differential?
Takotsubo.
Postpartum cardiomyopathy. For
Yeah,
peripartum
this is
cardiomyopathy.
peripartum. Yeah, peripartum cardiomyopathy. So if say you don't have the echo finding, any other differentials you want to add to this? So echo is not there. So forget about the echo. Anything else? So it can be pulmonary embolism.
Pulmonary embolism, amniotic fluid
And we have
embolism.
transfused also, Trali, Taco. Yeah. So all this could be a possibility. So that should be in your differentials. But because we have given the echo findings, it goes more in favor of, and even MI is also possible, correct? So though it will not be global hypokinesia, it will be a regional wall, but you should keep all these in your differential. Don't stick to this thing. So this is the case of peripartum cardiomyopathy. So what is the diagnostic criteria? Usually any heart failure in the last month of pregnancy up to 5 months postpartum. Keep this in mind. So from the last month of pregnancy up to 5 months postpartum is the definition. There is no specific definition. This is the definition which is followed by most of the guidelines. So, and you should not have any other identifiable cause for heart failure. Okay, so you should not have any other cause. And how do you say, even if the systolic function is less than 45% with or without dilatation, that is adequate to make a diagnosis. So, any patient had new onset heart failure from last month of pregnancy to 5 months postpartum also. Okay, then you should not have any other known or identifiable cause for heart failure. Like I told you, it should not be there. Any other reason should not be there. And EF should be less than 45%. How do you manage this patient? So this is the criteria. How do you manage? So initial evaluation. So confirm the diagnosis. How do you confirm? Do ECG, blood test. Mainly you're trying to rule out other conditions. Okay. So after that, so based on whether your patient has severe peripartum cardiomyopathy with cardiopulmonary distress or without cardiopulmonary distress, what do you do? So if there is cardiopulmonary distress, then you should optimize your preload. So give, if it is hypovolemia, give some volume. If it is hypervolemia, give some diuretics. If the blood pressure is more, you give some vasodilators. Optimize the oxygenation. You can give HFNC, NIV. So if very bad, you can intubate the patient also. The BP is low, add some inodilators or vasopressors. Urgent delivery, because only if you deliver, this condition is going to become better. So because in this they have found that prolactin levels are very high. So remember, another point to remember for you is about the timing. I told you these patients will have it in the last month. So as the term nears, so there is increased production of prolactin. So remember, prolactin is necessary for breastfeeding, for lactation. So your bromocriptine is the anti, it will inhibit your prolactin levels. So you can remember the timing of last month of pregnancy and 5 months postpartum. So that is when you will be breastfeeding the kid. So that is how you can remember it. So one of the drugs used is bromocriptine, because it will inhibit prolactin levels, because they have found, I mean, they've thought prolactin has some role in peripartum cardiomyopathy. So these are the drugs which are there. So consider mechanical circulatory support, refractory cardiopulmonary distress, recovery, like how you go ahead with any other heart failure. So you can consider any support devices, mechanical circulatory devices, finally going to transplantation or weaning. This goes this guideline. So what if it is without distress? So this distress is there, you don't consider antepartum, postpartum, nothing. You just go ahead with managing the patient, optimize the patient, and deliver the baby. If it is not there and it's not very sick, then what can we do? If it is antepartum, give anti-failure therapies, diuretics, consider delivery as early as possible. If it is postpartum, heart failure therapy, again, you can give ACE inhibitors. You can't give it ACE inhibitors in your antepartum period, correct? Because it will cause fetal abnormalities. So you're not giving ACE inhibitors. If it is postpartum after the delivery of the baby, you can give your ACE inhibitors. Okay. So again, you can consider bromocriptine. So and things. So this is how you manage a patient with peripartum cardiomyopathy. This is again is from the European Society guidelines. Okay. I think European
Is there
Society.
any role for low molecular anticoagulant? Is there any role?
I mean, as per this chart, it is not mentioned. So I don't think so. I mean, if there's any risk for prothrombosis, you can give. Otherwise, no role. So anticoagulation is not mentioned. Only it is a purely anti-failure. Usually they'll revert back. Usually they'll completely revert back to normal. But you should give some time. There is not been. If your patient has no risk of thrombosis, he's been ambulant, no need to give any anticoagulations. So no anticoagulation, antiplatelet, nothing is there.
Okay.
It's not a prothrombotic or ischemic event, correct? So it is just a failure. So that will usually recover after some time. So till then, you should just support and manage your heart failure. That's all.
Oh, okay.
So apart from this, mention two physiological changes. We all saw the physiological changes in respiratory system in pregnancy. Anybody wants to comment on the cardiovascular system? What happens? I told you there is hemodilution. So these are all the significant things which will happen. So uterine blood flow is significantly increased. RBC mass is increased, but plasma volume is increased more than the RBC mass. That's why there is hemodilution. Both will increase, but your plasma volume is increased more. That's why there is hemodilution. So systemic vascular resistance is altered, cardiac output, heart rate. So all of these are changed. Okay, if they ask you any case of pregnancy, they may ask you about the physiological changes. So next question. A 77-year-old male patient recently diagnosed with non-Hodgkin's lymphoma came with history of fever on and off since 1 week. Okay, he had multiple petechic bilateral pitting pedal edema. He had severe anemia for which a few investigations were done, which showed HbO 7.2, total counts of 1,100, platelets of 68,000. On examination, on ultrasound, there was hepatosplenomegaly, some bilateral effusion with some minimal ascites. So his fasting triglycerides were done, which was 450, ferritin was done 7,500, and fibrinogen was found to be 100. So what could be the case?
HLH?
Yeah, so I think I made it very obvious. So you'll not get only so many, you'll get 100 investigations. In that, you'll have to pick up the important ones. So this is a case of HLH. You have, I think, almost most of them in the criteria also. So what is the probable diagnosis? HLH, that is hemophagocytic lymphohistiocytosis. How do you make a diagnosis? Anybody?
Polycythopenia, fever.
So this is the criteria. Name of the criteria, HLS 2004 criteria. It is mainly used for pediatric. There is no specific adult guidelines, but this is what is used in all adult recommendations. So HLS 2004 criteria. Okay. So there are 8 parameters. In that 8 parameters, you should have at least 5 to make a diagnosis. So one is your diagnostic criteria includes 5 of the 8. I told you fever should be there, splenomegaly, cytopenias, at least 2 cell lines. Okay, in our patient, I think we had all 3, correct? So hemoglobin less than 9, platelets less than 1 lakh, neutrophils less than 1000. No, I think neutrophils, or this is neutrophils, or WBC itself was 1000. So hypertriglyceridemia and or hypofibrinogenemia, hemophagocytosis. So evidence of hemophagocytosis, either by doing a bone marrow study or spleen biopsy or lymph nodes. You should do a biopsy and check if there is hemophagocytosis evidence. Low or no NK cell activity, usually not done all the places. Ferritin levels very high, more than equal to 500 micrograms per liter. And you see, there's something called soluble CD25 or soluble interleukin 2 receptor levels more than 240. So this is the criteria. Okay. So in this, at least 5 should be there to make a diagnosis of HLH. Again, there is primary HLH, secondary HLH, and things like that. So how do you manage? Again, that is called as HLH 94 treatment protocol. So these are the components which are commonly used. So there's something called initiation therapy, continuation therapy, and usually some of these patients will end up in hematopoietic stem cell transplant. Okay, so usually they require bone marrow transplant and stem cell transplant. So just remember the drugs, don't need to worry about the dose. So the drugs commonly used are your dexamethasone, methotrexate, and etoposide. So all of these drugs. Okay. So this is again, these slides are there. So this is from the latest guidelines. Okay, this is the latest recommendations which is available. So this is how you'll approach a case. So patient clinically stable. So identify and treat whatever is the trigger. So any trigger would have precipitated. In this case, it is malignancy, correct? So usually any malignancy can also sometimes precipitate. Okay, so identify the cause and treat it. So the patient will usually improve. Okay. Patient deteriorating or unstable. So then you should consider giving IVIG is also one of the recommendations. So primary, I told you primary HLH, secondary HLH. So these are all the drug therapies. I told you any of these corticosteroids or doxorubicin, etoposide, methylprednisolone, IVIG. You can read this flowchart. Okay, this is summary of what are all the drugs available. Anakinra, all these are there. Okay. So next question, a 47-year-old male patient, a known case of diabetes mellitus and IHD, was brought with history of burns following an explosion at a workplace. So he had superficial burns involving the anterior part of both upper limbs and anterior chest and also the abdomen. So no other significant injuries. So vitally stable, except for mild tachycardia. He was conscious and he was little apprehensive. Okay. So next question. So how do you assess burn extent, or how do you assess?
Rule of 9.
Rule of thumb.
Yeah, one is rule of 9. Next, Wallace rule of 9. Other ones?
Uh,
Okay, the most specific one is your London Broader chart. Okay, you get age specific. And other one is simplest one is your outrage palm. Okay, that is again very subjective one. So you should either say Lund Broader chart or Wallace's rule of 9. Okay, so this is how you assess the extent of burns. So this is the London Broader chart, and it again age specific ones also comes. And the third one, this is your rule of 9, Wallace's rule of 9. Okay. So what are the indications for admission of a burn patient? I think we have finished this. I think I'll skip this again. It is repeated here. So apart from that, which have we missed any pediatric? So very elderly or very pediatric, you should admit them to the ICU. Oh, we did not do this, correct? We only saw about intubation. Okay, so what are you considering ICU admission? So any adult patient with more than 20% total body surface area involving, excluding first degree burns. First degree burns, no need to worry. But if anything, either second or third degree burns or deep burns, if it involves more than 20% of the body surface area, or third degree burns involving more than 10% of the body surface area, I need to admit them to ICU. Children less than 14 years, any age extremes should be admitted. Any inhalational injury with obvious or may have a risk of airway involvement or inhalation injury evidence is there, you admit them. So altered mental status or shock is there, you admit them. Circumferential burns, which can compromise the respiration. Say you have a burn on the chest and it can compromise the respiration, or there's a limb burn on the limbs, which is involving the entire circumference, then you need to admit. So anybody who's at risk of developing a compartment syndrome, you should admit. Anybody with organ dysfunction and it is associated with major trauma. So here there was blast, correct? So we don't know if there's any major trauma, you need to admit them to the ICU. So how do you fluid resuscitate? You all know this, I think. So Parkland formula, or there is something called modified Brooks formula also. It's almost similar. So how do you calculate the 24-hour resuscitation fluid is 2 to 4 ml per kg per percent total body surface area. In this, as per Parkland formula, you give 50% of this in first 8 hours, and remaining 50% you give it over 16 hours. And you also monitor the urine output, and the target is to reach at least 0.5 to 1 ml per kg per hour of the urine output. And again, crystalloids is a recommendation. Few recommendation there is also for albumin to be given. If you have given extensive fluid, large amount of fluid, then you can think about giving albumin as well. So any formulas, anybody knows formulas for burn nutrition calorie assessment? So
No.
So the most commonly used one is called Curry formula. You can use your Harris Benedict as well, which you are using it for routine practice. But only thing is, after calculating, you all know Harris Benedict gives you the resting energy expenditure. So okay, after that you should multiply it with the stress factor. For burns, it is so based on the severity of the burns, you should multiply it. So if it is less than 10% involvement of the total body surface area, you multiply with 1.2, 10 to 20%, 1.3. 20 to 40%, 1.5, and if it is 40 to 60% burns, it is 1.7. If it is more than 60%, you should multiply with the stress factor of 2. Or the formula commonly used is your Curry formula. The formula is 40 kilocalories into total body surface area burned plus 25. That means, so you are usually calculating this 25, correct? So 25 kilocalories into ideal body weight is what you are doing in your regular ICU patient. So to that, you should add 40 kilocalories extra for the surface area burned. So that is what is your Curry formula. Very simple. So routinely you give 25 kilocalories per kg body weight in your regular ICU cases. To that, if you add extra 40 kilocalories per percentage burn area, say for example, it is 10% burns, so 40 into 10 is 400 kilocalories. So apart from you are giving 25 kilocalories into body weight, plus you will add little 400 to it. So that is your Curry formula, very commonly used formula. So other than that, you have your Toronto formula or Eritton-Jones. So these are the commonly used formulas to calculate calorie requirement in burns patient. Okay, next, last question, I think. So, what is this? A 37-year-old female with twin gestation after fertility treatment came with complaints of pain in the upper abdomen on and off at 28 weeks of gestation. So, this was associated with nausea, vomiting, and some generalized malaise. There's no history of previous comorbidities or surgeries or blood transfusions or drug intake or hospitalizations. Lab showed HB of 8.8, total counts of 10,000, platelets of 88,000, creat of 1.2, sodium 131, potassium 3.7, calcium of 8.9, bilirubin 1.7, AST 128, ALT 270, ALP of 155, albumin 3.7, LDH 600, haptoglobin less than 40. So you did a peripheral smear, showed microcytic hypochromic RBCs, normal WBC, low platelets, few cystocytes and some burst cells. USG abdomen, nothing significant. So what do you think this is?
Help.
Yeah, correct. So there is hemolysis, there is elevated liver enzymes, and there is low platelet counts. And characteristic presentation upper pain abdomen, 28 weeks of gestation. So HELP syndrome. So it is seen in, it is one of the variant of severe preeclampsia. We've already seen it during our CCS discussion. And it is seen in up to 12% of the patients with preeclampsia. And also seen in 10 to 20% patients, even if the blood pressure is normal. So any diagnostic criteria for this?
Tennessee classification.
Yeah, there is Tennessee and Mississippi. Okay, so two diagnostic criteria. So platelets, AST levels, and LDH. So based on that, you can classify help severity, and you can make a diagnostic criteria also. Okay. How do you manage? Again, I told you only definitive treatment here is delivery of the fetus, stabilize the maternal clinical condition. So differential, ELF and AFLP. So these are the differential. I'll skip this. I think we already discussed both of them. Any score? Yeah, this one. So you can use the same MELD score for liver injury. So any patient with already liver injury. So what is the risk? You can use the MELD score. So predicts decomposition of previous. So if your patient already has a liver disease and now she's become pregnant, so what are the chances of this patient having a decompensation of the liver disease? So how to expect? I mean, how to measure this or how to estimate this? You can use the MELD score. So like we already, I mean, you usually use it for other liver diseases, correct? So you can use it here also. And if the score is more than equal to 10, there is high chances that your patient can have a decompensation. Okay. Last question. A 60-year-old male patient in known case of renal cell carcinoma, post-radical nephrectomy and chemotherapy a year back, came with complaints of gradual worsening back pain, which is very severe and associated with bilateral lower limb weakness since last 2 weeks. So history of not able to pass urine and sudden inability to walk since this morning. On examination, there's some bilateral lower limb weakness and loss of sensation in the perineal area. So what could be the diagnosis?
Cord compressions.
Correct. This is a case of cord compression syndrome, spinal cord compression. It's an emergency. Okay. So how do you want to evaluate? Again, neurological examination, do a total spine MRI. This is a gold standard. Okay. If at all there's any contraindication to MRI, you can do a CT scan with or without contrast of the entire spine. How do you manage? So there will be significant pain control. You give opioids. You can even give steroids that will also reduce the amount of pain. Urgent neurosurgery and radiation oncology consultation. Okay. If surgery is not indicated, then you can go with radiotherapy. So both the consultations, usually surgery is required, but if your patient is not fit, then you can go for radiotherapy that will usually salvage the spinal cord. Okay. So that is the discussion. So any doubts you can ask. So I
Sir,
think
can you provide us a clinical feature or sign of the about level of the compression according to the level of compression?
you want me to? I'll try to get one and post it in the group. Okay. So
Inshallah.
based on
Okay,
level
thank
of
you.
okay. Yeah. So any other doubts? So I've tried to cover all important topics in the three commons in burns, drowning, pregnancy. So we have covered most of it, and even oncology. So look into newer treatment modalities, which are there, any newer complications. So we need to be updated about it. So any doubts?
Yes.
Okay. If there are no doubts, okay. Thank you then. Happy weekend, everyone. So all the
Thank
best
you.
for your exams. I think you have less than a month now.
Yeah. Thank you.
Okay. Thank you.
Thank you, sir.